Good morning, everyone. Welcome you all to the third day's scientific presentations. To begin with, let us start with our first session of the day with Professor Lisa Laxo, Associate Professor, Physiotherapy, Academic at Griffith University, Australia, still consult clinically. Immediate past President of World Association of Laser Therapy, Australian Medical Laser Association Executive Member, using and researching, teaching laser photobiomodulation for more than 25 years. I welcome Dr. Lisa Laxo.
Good morning, colleagues. It's very good to be here, and specifically I wish to acknowledge our US delegates and speakers today on this day that is important for them. I wish to acknowledge the organising committee and particularly the conference chair, Dr. Murthy, and thank you very much for the opportunity to come along over these 3 days in Bangalore to discuss what's a really important initiative for India, I think, and for healthcare practice in India. So thank you very much again for inviting me along. The topic for today is clinical application for laser PBM. I'm not sure why my slides are not up on screen as yet. And I might just wait until we get that connection. Thank you very much. So the topic for today was the clinical application of laser PBM therapy for inflammation, pain and tissue damage. Now, of course, those of you who are familiar with this field will know that you can't deal with each of those things in isolation. They happen together, particularly in the acute setting. For the purposes of this particular presentation, though, I am going to try and unpick those various areas and try to look at the highest level of evidence in each of those areas. But I will be looking at it from the purposes or the perspective of clinical application. So I'm going to try and be an interpreter for the clinicians amongst you today, to try and interpret what we've seen from the research and what we've seen over the last couple of days in relation to the evidence, and to try and put that into a clinical perspective for you. So this is what I would be trying to cover today. It's a lot, and so I really only will be scratching the surface, going through inflammation, looking at the acute aspects of that, recognising that the chronic aspects do include a lot of the kinds of cytokines and cellular messages that are involved in acute inflammation, but that they are in the context of chronic disease. Unfortunately, I don't have time today to really spend a lot of time on that. And then we'll look at pain, acute and chronic pain, and finish up with some tissue healing, mostly about soft tissue healing and the clinical application of laser PBM for that, but also some of the hard tissue work that's being done in animal studies in particular. So let's launch by looking at inflammation and acute inflammation, reminding us all that there are 3 stages to healing, that the acute inflammatory stage is, depending on the definition, over the first 72 hours or so, and then we work into the proliferative stage and the remodelling stages. And there are lots of different cell types that are involved in that. If we think of, this is an image from some work or a review paper that was put together almost 10 years ago now, but it essentially illustrates the complexity but the coordinated efforts of different types of cells within the immune system, and that each of those has a distinct role, and the messengers that are involved are quite complex, and we're getting better information about all of those all the time. Now, if we put that into the context of what laser therapy or PBM therapy is capable of doing, I've just chosen at random a range of publications there. You can see the authors there in the bottom right-hand corner. This is just a random selection. It's not a complete selection at all, but you can see the different types of cytokines and growth factors that have been found to be either anti or pro-inflammatory, and we've heard a lot about that over the last couple of days. And more specifically, some of the wavelengths and different dosing characteristics that have been used to either increase or decrease those growth factors and cytokines. And if you're interested in some of this work to get a better feel for the vast array of growth factors and cytokines that are released from cells in culture, then this particular review paper is a very good one, Phil Peplow and colleagues. So if we try and put this into a clinical perspective then, this was a paper that was put up briefly by James a couple of days ago by colleagues in Norway, Jan Bjordal's team and colleagues of his in Brazil. The application was one application of 904 nanometer laser. You can see the characteristics there of the laser, and it was applied to activated Achilles tendonitis. And the results were pretty clear, and I'm just going to have a closer look at those results. So the mean pressure pain thresholds increased in the laser group. The actual amount of that increase is quite small, but it's indicative of the kind of results that are possible in a clinical setting. And then if we look at the prostaglandin E2 concentrations, very significant reduction in those compared to control. So there is good evidence around just one application of PBM therapy for acute tendonitis and the effects of that from a potential clinical perspective. So I'm going to zip straight into acute pain because you can't really do acute inflammation without considering acute pain. And if we look at a systematic review of the possible mechanisms of action and clinical effects from randomised placebo-controlled trials, again from Jan Bjordal's group, you can see there that that group of authors found that laser therapy or PBM therapy modulates inflammatory pain by reducing a range of factors there, and they're listed there in that first dot point. But as well as that, it's about a reduction in the formation of edema and potential hemorrhage as well. There was a vast array of, or vast range of doses that were used or found in that particular systematic review. The important point to note there is that when optimal doses of PBM are used, the effects are equally as good as using NSAIDs, and I think that's really important if we're looking at doing non-pharmacological management of pain and inflammation. Then laser or PBM therapy is going to be one of those effective methodologies without necessarily the deleterious effects of pharmacology. Looking at more particularly one of the most common clinical problems that we are faced with, particularly in physiotherapy and general practice land for medicos, acute low back pain with radiculopathy. This was a study, a double-blind, randomised, placebo-controlled study, quite nicely done. 3 different groups. The first group, and good numbers of patients, by the way. The first group where there was a combination of an NSAID and active laser therapy. The treatments were 5 times weekly for 15 treatments. And again, we've got the parameters used there for the laser. Group B only had the NSAID, and Group C had the NSAID plus placebo laser. And the outcomes were very positive in terms of statistical improvements in pain VAS scores, lumbar movement, disability scores, and quality of life scores. So statistically improved in all groups, but much better improvement in Group A, which had the active laser. So how do we use this information for clinical application? It's one of the big questions. We've got some information that the World Association for Laser Therapy has pulled together. It's a good starting point. The documents, the frameworks and recommended guidelines are getting a little old now. They need to be updated and reviewed because we have more wavelengths now being used, and certainly the application of laser or PBM therapy is being used in a vast array of different indications. But I've circled a few different aspects of that particular document there. This set of guidelines was developed for those wavelengths 780 to 860 nanometers, and you can see down the bottom that there's some advice there on how often to treat. So those of you who are clinicians might be interested in accessing these particular guidelines. The other thing I'd like to draw to your attention here is that when you look at the joules that were used in the studies from which this evidence-based guideline was developed, for deeper structures such as the lumbar spine and hip, we're looking at much greater requirements for dosing as opposed to more superficial areas such as the lateral elbow. So these are important pointers for how we might apply laser in a clinical setting or PBM therapy in a clinical setting. This is the other set of guidelines for 904 nanometer laser. And again, we see the same kind of thing where we've got deeper structures such as the lumbar spine and hip. The amount of therapy required or dosing required is much more than required for a more superficial structure. So it gives us a little bit of a flavour of how we need to approach our clinical application, and I'm going to develop that a little bit more as I go on. Excuse me just for one moment. How does laser work? We've over the last couple of days we've heard a lot about mechanism and the fact that it's possible for pain to be blocked by the use of PBM therapy. Now, in a systematic review that we did a few years ago now, we established a number of principles in that in human studies, the application of laser transcutaneously can inhibit action potential, so blocking nerve conduction in underlying nerves, and in animal studies that laser selectively suppresses the A delta and C fibre action potentials. So if we look at that in a little bit more detail, and I want to recognise our colleague Roberta Chow now, who's done the seminal work in this area. If we think about where A delta and C fibres, the nociceptors, actually lie in the body, they're very superficial. So we're talking very superficial in the epidermal layers. And this is where laser is actually going to have its primary effect, in those first few millimetres of tissue. So laser acts locally on peripheral nerve endings in the epidermis. It has the capacity to reach deeper structures as well, but for pain, the specific requirement to reach deeper structures is not necessarily there. As Roberta says, some of the peripheral nerves are up to 1 metre in length, and this makes peripheral nerves quite unique in that you can treat them superficially, but they will have, in terms of the ascending projections of those nerves, have direct contributions to the central nervous system. The other thing that I'll point out in this particular slide is the descending mechanisms as well, and although I'm not talking about it today, this is an area of work that I've been involved in, is looking at the endogenous opioid and descending inhibitory systems and how they might affect the mitigation of pain in a clinical setting. So moving on from there, again acknowledging Roberta's generous offering to allow me to use some of her slides. Roberta's work has looked at fast axonal flow transported mitochondria and noted that there is a reversible or temporary disruption in that fast axonal flow and the development of varicosities in those nerves. And 2 slides here to demonstrate that. This is the control axon showing normal fast axonal flow, and you can see over a period of 10 minutes or so that these arrows are gradually increasing and demonstrating that varicosity or the fast axonal flow, I beg your pardon, does change without the application of PBM therapy. When the axon is irradiated with laser, then that movement virtually comes to a standstill. And that's what we're talking about in terms of the blockage of nerve stimulation, or blockage of nerve impulses, and the anaesthetising or paralysing, if you like, of those nerves that we've heard a bit about over the last couple of days. So if I now go on to look at chronic pain, we need to, and those of you who work clinically would understand that chronic pain isn't necessarily accompanied by inflammation and or tissue damage. It's often something that sits on its own and has its own field of research around it. So we need to bear that in mind, that there may not necessarily be tissue damage or continuing tissue damage or inflammation. There may be some, but chronic pain is an entity on its own. Having recognised that, there is some good evidence, collated evidence in this area in terms of systematic reviews and meta-analyses. Again, Roberta's work and colleagues in the publication in The Lancet a few years ago, the interpretation of that systematic review and meta-analysis was that laser therapy reduces pain immediately after treatment in acute neck pain, but also up to 22 weeks after completion of treatment in patients with chronic neck pain. And that's a really significant point for this field of healthcare practice. So I want to now look at how we might apply laser to neck pain. If we think about what overlies the structural elements of someone who's got chronic neck pain, we've got superficial nerve endings, A delta and C fibres. Superficially, we've got a number of muscles that underlie the skin there, within which there might be trigger points or acupuncture points, as we heard yesterday from Dr. Dorsha. And under that, of course, we've got a range of different nerves and vascular structures, as well as joint structures, which we might wish to affect with laser. From my perspective, from a clinical perspective, we could treat any one of those points using a single probe, and I'm just indicating there with little stars that you might see as they come up here. I could treat any one of those points, targeting those points with a single probe. In more recent times, I've been using a 3-diode probe, a 904 nanometer probe, so that I can actually span those target points more effectively, I suppose, or maybe perhaps not more effectively, but do so in a more time-efficient manner, applying the dosage more rapidly than using a single probe. And this is the way that I would do that clinically. I would actually apply this 3-diode laser, and in terms of kind of thinking of the word, in terms of my declarations of conflict, I purchase my lasers from a number of different companies, so this is one that I'm using at the moment for this purpose. So I will apply the laser across the spinous process and the facet joints on both sides at the same time, doing that at various different levels depending on the patient's symptoms and signs, and perhaps moving the laser out to different points along the trapezii or across trigger point levels, wherever the assessment of that patient and the patient's symptoms suggest that I should apply that. What I've done recently as well in chronic neck pain is apply the laser to the supraclavicular fossa and in the region of the stellate ganglion, and I'm finding that that is actually quite helpful in reducing some of the autonomic nervous system signs that some of these people with chronic neck pain are actually experiencing. When we come to low back pain, there is also some high-quality evidence here, meta-analysis. James referred to this the other day. Moderate quality evidence, only seen following high laser doses. above at least 3 joules per point, and interestingly in participants with shorter duration of back pain, so less than 30 months. So from a clinical perspective, I think the message there is for us to start using PBM therapy as a first rather than a last resort, which is often the case in chronic pain. How do we apply laser then for people with chronic pain? This is a study that was done by Ali Gur and the group in Turkey. There's a range of information here in this extract from that particular paper. Again, treating 5 times a week, in this case for 4 weeks, targeting a range of areas, specifically to the lower back, the lumbar and sacral spine, the apophyseal capsules, the dorsolumbar fascia, interspinous ligaments, as well as the gluteal fascia and ligaments, and of course further down into the leg, the gastrocs and the hamstrings. So quite a long process potentially here, trying to deal with a multitude of presentations that can occur with chronic low back pain. And you can see there the range of laser parameters that were used by this particular group. Now, based on that information and based on conversations that I've had with Roberta Chow about this, we've been developing a protocol for treating people with chronic non-specific low back pain as well as post-surgical low back pain. And this is the kind of strategy that we've come up with. Again, using that 3-diode laser that I showed you before, applying that 3-diode laser straight down the centre of the spine as well as across the erector spinae group of muscles, down into the area of the SIJ and the sacral elements, the outlets of the quarter equina, and the potential is also there to, Roberta says that she treats along the costal margins as well. I've also found it useful in clinical practice to come out here along the iliac margins as well, because people do complain of pain in that area. So using that approach, we've been getting some really good results for chronic intractable low back pain. There are other areas of the body, obviously, that have problems with chronic pain. Knee osteoarthritis is one of those that has been studied for PBM therapy. This is an interesting paper I thought that I would put up because it actually has a really good message for us from a clinical perspective. This particular systematic review and meta-analysis noted that there were 4 studies conforming to the WALT guidelines that I put up earlier, but that between laser and control there was no difference after treatment or at 12 weeks follow-up in any of those outcome measures, which was really interesting to me. And I started to wonder, why is that the case when we're getting such good effects in some areas of the body using those evidence-based guidelines, but not in others? What's the clinical implication of that? And if the doses conform to the guidelines, are we actually targeting the right area of the body, or of the knee in this case? So when I had a look more broadly at some of the other fields of work in electrophysical agents, there was work that was done some years ago now, looking at the efficacy of transcutaneous electrical nerve stimulation for knee osteoarthritis. And it was felt that unless these particular nerves were actually targeted, and in particular the infrapatellar branch of the saphenous nerve, that it was not going to be possible to get a good effect using electrical stimulation for knee pain. And so perhaps there's something that we can learn out of this in terms of our targeting of PBM therapy in clinical practice, that we are more selective in how we target or where we target. And Dr. Dorsch's work in this area I think is really important for us to understand how we might better select our target points in clinical practice. If we look at other kinds of common clinical presentations, tendinopathies in particular, the tennis elbow, again a systematic review where primarily 904 and 632 nanometer wavelengths were found to be effective for short-term pain relief and for improving disability in lateral elbow tendinopathy, and that was both alone and in conjunction with exercise. And I'm going to come back to that adjunctive use of laser in a little while. You can see there again a significant range of doses that have been used. A systematic review with a meta-analysis by colleagues in New Zealand, Steve Tumulty, on tendinopathy. I'm just going to quickly zip through these slides, indicating that for lateral epicondylitis, for pain, that forest plot indicates that the outcomes favour laser. For grip strength in lateral epicondylitis, again, the outcomes favour laser on that forest plot. For rotator cuff pain, again, the meta-analysis indicates that the outcomes favour laser. For Achilles tendinopathy, the outcomes favour laser. So there's lots of really high-level evidence for the use of laser or PBM therapy in tendinopathies. And this is an area that I've been researching for a number of years now, translating clinical evidence, animal studies into clinical evidence. And some of the work that we've done has been looking at the physiological effects of laser and the outcomes of that. And in this particular study, we looked at 780 nanometer laser at that particular fluence to the three most tender spots of the lateral elbow, looking at blood flux. And you can see there that the treatment group, the laser group, had significantly increased levels of blood flow in the periphery when the laser was applied at the elbow compared to control and placebo. When we look at mean arterial pressure, again, laser had significant reductions, statistically significant reductions in mean arterial pressure compared to control, but interestingly, placebo also resulted in significant reduction in mean arterial pressure. The question there then is, what is the mechanism behind that? And my theory all along has been that there is a sympathoinhibitory or opioid response to laser phototherapy. And we know that the placebo response works through a very similar mechanism through the sympathoinhibitory pathways. How quick is that primary effect? We heard yesterday and the day before Praveen talking about the primary effect of PBM therapy. In chronic pain in this lateral epicondylitis or epicondylalgia model, we've looked at this. We've had a look at how quick the onset of these physiological responses are. This is skin temperature on hairy skin. Just explaining the graph here, we've got a pre-intervention data collection period of skin temperature. This period here is the application of laser, and then we've got a post-intervention period of data collection. You can see that within the space of seconds of the commencement of the laser application, we start to get an increase in skin temperature in pilous or hairy skin. And we would expect a reverse of that in glabrous or hairless skin, and that's exactly what occurs. It takes a little longer for that effect to begin, but it does occur, and as soon as the laser is switched off or the treatment is completed, then skin temperature begins to rise, but it doesn't return back to the same level that it was in the pre-intervention phase. We've been following that up with some quantitative sensory testing in recent months, and I want to recognise a couple of Brazilian colleagues, Pinfildi and Thomas Burke, who have been helping with this at Griffith. This is hot off the press in respects that we haven't yet prepared. Well, we are preparing this for publication, so I would be grateful if you would respect the confidentiality, if you like, even though we are web streaming, confidentiality of this data. Sorry? Oh. This is weekly treatments of 904 nanometer laser with increasing doses each week. So we would start with 1 joule. The following week, after 1 week of what we thought was washout, we would go to 2 joules, then 3 joules, then 4 joules, and then we would have a 1 month follow-up. And you can see there that for worst pain at 24 hours, worst pain over the 7 days prior to that application, and rest pain, we can see that there's a reduction for all of those indicators across that methodology of treatment for pain VAS. Now, this was a cohort study. We recruited 19 participants with lateral epicondylalgia, and we were looking at testing the immediate effects on autonomic system-mediated outcomes. And we were treating 6 points around the elbow. Now, those are the points that we chose, and I'm not going to go into the specifics of that because that's still the stuff that we're preparing for publication. But it's interesting when we look at that, those different points, that and measuring blood flux, that there seems to be selective outcomes based on dosage. So for 1 joule and 4 joules, we were seeing an improvement in blood flux, but for 2 and 3 joules, we were not seeing the same kind of effects. And that was particularly evident at those early time points immediately on application of laser and at 3 minutes. When we look at the various points at which we actually applied the laser PBM, we'll call this P1, 0.1 and 0.5. They had the most influence on blood flux. You can see there that when we applied the laser at other points around the elbow, that we didn't get the same kind of effect on blood flux. That, if we look at P1 as an example of this outcome, so P1 was this area here where we applied the laser over a vascular structure, we can see that the effect with 4 joules of laser, that was significantly greater than it was for placebo at 4 joules or at rest in between times. So how do we use that information clinically? Now, people who know me will know my little analogy about pulling up at a petrol station. When you go to the petrol station, you choose the kind of petrol that you're going to put into the tank. We have to make some decisions about what kind of energy we're going to use for our particular vehicle. So there's some choice required here about what we're going to use. We need to think about where we're going to put that petrol. There's no point in just pouring the petrol over the top of the car and hoping that the energy is going to leak in somewhere to ignite the engine. Neither are we going to leave our petrol pump just unattended on its own. We need to have some kind of thinking process around how we apply that energy to our vehicle. So I think it's a nice analogy for laser therapy. We need to think about what it is that we're using and where we're applying that particular energy. So as an example then, for clinical practice, if we're thinking about lateral epicondylalgia, we need to be promoting repair and remodelling of the tissues in that area. So we would hope that one of the aims of our treatment is going to be getting vessel and nerve regression as part of that healing process, that we're going to get stronger collagen fibres, and that the tendon needs to become less thickened and more load resistant. We also want to provide pain relief so that we can then start to address some of the underlying biomechanical alterations through exercise. So when we put this together as a multimodal treatment, looking at the evidence, we know that Mulligan's mobilisation with movement, those physiotherapists in the audience will understand what I'm talking about there, that has a good evidence base for lateral epicondylalgia. We also know that exercise, specific types of exercise, have a good evidence base for improving lateral epicondylalgia. There is not a good evidence base for bracing, for tennis elbow pain, but we are now seeing a really good evidence base developing for the use of laser PBM for lateral epicondylalgia. So if we put all of those things together, hopefully we're going to have a really happy client. And that's where a multimodal methodology of treatment is going to be really useful in clinical practice. How am I going for time? Okay, thank you for that. All right, so that should give you enough time then. Tissue healing then. Again, I'm using a meta-analysis here, tissue repair. We've seen over a period of time that There's good evidence for laser in animal studies, but not as the evidence is not as good in human studies. Wound PBM therapy 101 a la me. I teach this at my university. I tell my students that our aims for managing wounds are to facilitate granulation tissue formation, to promote wound contraction, and to increase tensile strength in that tissue. So this is from my clinical experience, but also bringing together what we know from the evidence. If you can imagine, this is a transverse slice of a wound. This is healthy tissue at the edges. This is our wound here. The way that I do this in clinical practice is that I apply infrared wavelengths in contact to the intact skin at the edges of the wound to optimise penetration of those photons and to encourage wound contraction or inward movement of the tissues. And then I also apply a different wavelength over the wound, not in contact from a hygiene perspective, but applying that over the open wound itself to optimise absorption of those photons at the target site and to encourage granulation tissue formation. Now that's really critical, I think, to have the two different wavelengths. I believe that when you've got your target tissue already exposed to the air, and as I say to my students, bathe me with light, that's what the tissues are saying. You don't need to have deep penetration for that. You need optimal absorption for that effect. So if we look at that from the perspective of an image of the wound, this might be our infrared laser in contact around the edges, and then over the wound we're going to select a few points to use our red laser. Now you'll see that there aren't many points that I've selected there. I've not put lots of points next to each other. At my first treatment I'm quite conservative in that. At my second treatment, the other point I would make here is that where you've got a little bulge perhaps in the wound where it looks as though it might be extending, always make sure that you treat a point there. At the second treatment, I might then move my points of treatment one order over so that I'm sharing the love around, if you like, in terms of the application and giving that area where I treated the first time a little rest. And the same thing within the bed of the wound itself. I'll treat different points that didn't receive treatment the first time, and so that over the period of a number of treatments I'm treating different areas of that wound. So as an example of how I've used this was a venous ulcer, a 15-year history of this particular ulcer. This was in the early days when I first started to use laser PBM for treating wounds. You can see some of the parameters that I used there. This was after the 7th treatment. We were starting to get closure. There was a little skin bridge that was starting to form here. After the 8th treatment, if I just go back, after the next treatment, I don't have an image of it, but that skin bridge had completely formed. So within the space of a few days, we had 2 little ulcers that we were dealing with. Progress slowed a little bit at 2 months, at 17 treatments. That's where we were at, but we had complete closure at 3.5 months, and we continued to treat for another 4 treatments to improve the tensile strength of that area. This is a pressure sore 24 hours after the pressure sore became evident. It was in the setting of palliative breast cancer. This was day 1, day 2 the following day, and you can see that there's a quite severe eschar that's formed in the area of the wound. That eschar has lifted by the next day, and we're starting to see a nice clean wound emerging with some lovely granulation tissue forming in some of those areas that received treatment the previous day. This is day 3, and you can see that this wound has healed completely, and these areas are granulating nicely, but there's still an area here that's a little bit slower to improve. So we can use PBM therapy quite effectively in a clinical setting. We just haven't got the specifics for proving this in randomised controlled trials. Briefly, hard tissues. Most of the work that's been done in this area has been done in animals. Interestingly, using red light, but with very good bone tolerances being improved statistically as well as in the laboratory setting using laser PBM. And you can see that in a forest plot that in a meta-analysis approach, helium-neon laser certainly is favoured in that analysis. And there are a number of my colleagues in Brazil in particular who are looking at using bioscaffolds and seeding different kinds of cells onto those scaffolds and using laser to promote the growth of those scaffolds. So I think we can probably see more work in this area in the future. So lastly then, I see PBM, laser PBM, as an adjunct to clinical treatment. It might be, in one treatment, it might be the only treatment that you give, but in other appointments it might be amongst a range of other things that you're doing for a particular client. I see that there are other areas of use of laser and PBM therapy for symptom control in cancer, in particular for lymphedema, and we've been doing some work in that area as well as doing some work in the area of preconditioning for preventing tissue damage and for aiding recovery after exercise. And they're fields of work that have really not been covered to a great degree here at this particular summit, but I would be very happy to come back and talk more about that in the future. So in terms of how we might collaborate with India on all this kind of stuff, well, those of you who are locals, talk to the people who have come into the country to talk about this area of practice. I think that we can develop lots of good collaborations. From my perspective as a physiotherapist, I'd love to develop a network of physios and others who might be interested in developing some evidence-based management protocols for the commonest problems that you see in clinical practice, developing some standardised methods that we can test, perhaps testing out some different treatment regimens, and choosing the most appropriate outcome measures, and making research part of your clinical practice, making laser PBM research part of your clinical practice so that we can add to our combined knowledge in this space. So thank you very much. If there's time, I don't know.
Nice talk. Very nice talk. Can you hear me?
No option.
Okay. It could be reverberating around here, and I wouldn't know. I'm fascinated by the wound healing and the preconditioning aspects. I have a couple questions and then a comment. When you say you start out with near infrared first, what wavelength generally, or wavelengths?
Yeah, look, in the end, it doesn't matter. It's whatever I've got available at the time. But I do both on the same day.
So something 904, 880.
Generally, for most of this work clinically, I've had somewhere in the 810 to 830 range.
Okay, and then the far red is 630 or 6.
Yeah, most of the diode, I've used mostly diode lasers in this space, so 650, 660.
Okay. Mm-hmm. So mechanistically, one of the things that came out of a conference I went to before, in terms of cardiovascular studies and isolated myocytes, from Martin Bienengraber and Nicole Lohr's work, is what they've seen at a cellular level is that 670 actually releases nitric oxide in tissue release from myoglobin and possibly even hemoglobin in their studies, and something in the 800 range doesn't do that. So really, in terms of looking at this as a photoceutical, each branch of wavelengths, there's probably some overlap because most of these photoacceptor molecules have a fairly broad band of activation, but they're not the same drug. So there's and I do see an advantage of sort of mixing and matching. So I'm fascinated by this. The fact that you can get closure of a wound like this in 3.5 months. I can speak to one case where Ron Ignatius of Quantum Devices was treating his own wife's diabetic ulcer, and with just 670 LED, and it actually took 6 months. So there's something, I think advantageous about combining the two wavelengths.
Look, Janice, I think part of the problem is that these wounds present in lots of different ways because the individuals have other problems, comorbidities that may be affecting how the PBM might be creating a response within the tissues. So I think that's part of the biggest.
I agree. It's every single thing, every single wound is a different disease.
Absolutely, yeah. And that makes it really difficult to do an RCT.
I know. I think it is very difficult. Pre-treatment. We did a study with spinal cord injured veterans at the VA hospital in Milwaukee, Wisconsin, and the VA was one of the few places that welcomed us with open arms and was willing to work with us in this kind of trial. Most of these wounds didn't go to closure. These individuals were actually in the VA facility so that they could clean up the wounds and basically suture them together so they could probably in about 6 months dehiss or unsuture themselves. But interestingly, we had 200% increase in, this is at 670 nanometers, treating 3 times a week for 4 weeks, a 200% increase in the rate of closure, and in those wounds, those treated wounds that were sutured, they held together significantly longer. So they're very interested in following up. I would love to see a light device put in the seat of every wheelchair so that for
prevention of pressure sores,
so that you could prevent pressure ulcers.
Perfect. I mean, Superman died of a pressure sore, so
exactly.
That's what I tell my students.
Thank you.
So you're going to have a lot of naked patients in wheelchairs then. The skin was sort of through their clothes.
That was a joke. Lisa, the rationale for ramping up the dose as you go longer out, isn't that counterintuitive to what you're trying to do with the inflammation and pain?
Look, it is. It wasn't our initial intention. We were specifically looking at mechanism and autonomic nervous system effects, and we thought that a 1 week washout would be sufficient. Clearly that's not what's happened, but you're right, it does mimic what we would probably do in a clinical setting.
On nitric oxide, so released from cells, Janice, rather than myoglobin and hemoglobin, I just found 10 papers using 810, 820, 830, 850 nanometers, 780, releasing nitric oxide from cells. So it might be different story. Really, the question I wanted to ask was about treatment of nerves. So our guru, Roberta Chow, I don't know if she's ever said this to you, but she would treat spinally for peripheral pain. So she would include treatment of the lumbar spine. She'd treat over L3 for pain in the knee, for example, and she'd treat segments up and above and below. And the rationale I heard for that is if you can hit the medial and lateral branches of the spinal nerve, you can induce analgesia there. And she's trying to make some sense of this, but these very short, you were talking about the 1 meter long fibers, and that kind of had me thinking for a moment. Because you remember her saying how these very short fibers seem to suppress the ATP production in dorsal root ganglion and induce analgesia for the whole dermatome.
Yes.
Anything I haven't seen is any evidence for that. Do you know of a reference for that effect?
I think the evidence is piecing together a number of things that have been found both by Roberta and what's been in the literature. I think we have not yet provided absolute proof of that as a mechanism or an effect in the one study, and I think that would be the next challenge to try and do that.
I think she's drawing on acupuncture, isn't she, a lot for that effect?
Exactly, and I think the acupuncture approach is we can learn a lot from that in terms of targeting the anatomical structure which we believe is causing the pain or whatever it is, plus targeting the spinal nerve root, for example, plus targeting acupoints or whatever. I mean, Roberta and her colleague Anne Liebert talk about really bombarding a large area in lots of different places to get the best effect. I think in bombarding or using a shower kind of approach or a scanning approach, there are two problems from my perspective. One is the repeatability of the dose. How do you know that you're moving things as quickly or overlapping or whatever? But secondly, do we need to do that much? From that tennis elbow work, it's clear that we probably don't need to treat 6 different points. We probably only need to treat 2 points.
We've got the lateral epicondyle itself, and then there's going to be myofascial trigger points as well.
Yeah, or a vascular structure. So that's what we're trying to learn out of this is how much is enough? Where's the threshold for application? How many points do you have to treat? What are the target structures? So that's the kind of stuff that I'm trying to unpick.
Well, if you want to unpick another one, I think you Konstantinovich, you referenced up there, and radicular pain. I think you did a neck one, but she did the back pain as well. She was using something like 100 milliwatt 904 laser. This is not going to adequately reach nerve roots and induce analgesia. That's a long way down, and you need a high radiance to get that effect. If she, relatively, that's not a lot of treatment for a 5 centimetre deep target. It's not. Clearly not how it works, yet she got good results. Yeah. Unless it is this indirect effect of treating spinal nerves where they become the superficial terminals. If you can overtreat these, something's working lower down.
Precisely.
That's the bit that needs to be worked out.
I don't disagree at all with you, James. I think all those comments are spot on. Yeah.
Thank you. Time for a break.
I think there's
one more hand.
I think there's one question after you, and then I think we should have a break so that we can...
Thank you for the excellent presentation. Very enlightening. I guess I can throw a little light on the question prior. At the L2-3 level is viewed as a huge autonomic outflow area in traditional Chinese medicine called Ming Men, gate of life, for all lower extremity radicular problems. And the thinking is that the inner bladder line and outer bladder line, they run at the medial branch of the dorsal ramus, outer bladder line at the lateral branch of the dorsal ramus. And the lateral branch, right where you're putting your new applicators, is a more autonomic innervation than the inner branch. Yes. But it's a whole other topic. But I guess one of the questions I had too was the Walt guidelines saying you need 4 joules for a hip or lumbar problem. Again, wouldn't that be somewhat inconsistent with the idea of Dr. Chow that you're trying to stimulate a superficial nervous structure?
Yeah, I think that was 40 joules in the guidelines. Yeah, and look, there are different approaches. People will have different theories on this. Depending on your theory or your clinical approach to this, you can make an argument about almost anything in this space, I think. The clinician in me says, if it works, then do it. The researcher in me says, okay, why and how, and what are the details? So I'm trying to span a bit of those two areas, and I think you'd probably do the same thing.
So Lisa, just a comment, and we've talked about this before, so it's no surprise for you, but we've talked about the Walt guidelines and kind of where they're at in this point in time, and I think from not just the work in my lab, but a lot of other people have shown to just say joules is meaningless.
Yes.
And so I think we need more data, at least time, energy, density, to really have any meaning at all. Because like I showed in my talk yesterday, I could give a certain amount of joules and cause inhibition in one case and stimulation in another. I'm just putting that out there for whatever it's worth, but that's one of the reasons I think we totally have to get away from this joule concept because it is meaningless. And so
I think you're absolutely right, and I think because India is almost a greenfield site in this, we've got to start at the right standard of nomenclature and conversations around this. So I think it's a perfect place to be doing some terrific work and developmental work into the future. I think we need to stop there, though. Thank you.
That was lovely, Lisa. So, with your last closing statement that India would be a nice greenfield arena to start in a structured way, when do you plan to shift to India? Let's break for a cup of tea. Yep. Welcome back, everybody. Sorry, I made the tea break a little too short. Well, after a short tea break, let me invite Dr. Mohammed Ajaz Habib. And Dr. Habib is a renowned senior gastroenterologist, a hepatologist, and has been doing a lot of work on stem cell therapy and regenerative medicine. And he's passionate about research work concerning stem cell research in liver research and diagnostics. So let me request Dr. Habib to enlighten us on his exposure in regenerative medicine.
Thank you very much. At the outset, I would like to thank Dr. Murthy, Dr. Gururaj for inviting me to be a part of this meeting, which is the Global Summit on Laser Therapeutics and Regenerative Medicine. At the outset, let me be very honest, it looks like I'm a little bit misfit in this setting, because being a clinician, being a gastroenterologist and hepatologist, my work centers around patients with end-stage liver disease and how these stem cells are going to work in these patients. This is the burden of liver disease throughout the world, and the etiology and the pathogenesis and the disease manifestations and the clinical signs and symptoms are totally different. In acute liver failure, this is a fulminant hepatic failure. The patient develops severe encephalopathy and goes into a shock and hypertension, and they are in critical need of liver transplantation. But patients with chronic liver disease, what you call as cirrhosis, there the histological hallmark is the fibrosis, as well as regenerative nodules, progressive necrosis simultaneously going on, at the same time regeneration also going on, and the etiology which I would discuss later on. But the endurance spectrum of disease is acute on a chronic liver failure. Acute on chronic liver failure is a spectrum of disease wherein patients develop jaundice and coagulopathy, and over a period of 1 to 4 weeks develop encephalopathy. And these are after a critical injury or insult because of hepatitis B, C, alcohol insult, or on top of that any sort of a infection which may trigger a patient with already pre-existing chronic liver disease to go into a sort of a decompensation. These are the people which we are primarily looking at as a target population, wherein we are implying that if we give benefit to these patients in stopping the conversion to acute liver failure or decompensation, or extending the runway to so-called liver transplantation by stem cell regenerative therapy. As you know, liver cirrhosis is a very dangerous end-stage liver disease. 5 million people suffering from liver cirrhosis in the United States alone, and the third leading cause of death in Southeast Asia, whose only curative therapy is liver transplantation. Prognosis depends on the clinical stage of the disease as well as the associated complications and comorbidities. Approximately around 5,000, this is going on increasing, around 5,000 liver transplants are performed in the United States each year, and almost like 20,000 people are waiting for the liver transplantation, and as many as 1,500 patients die yearly on the waiting list. In India, the situation is further worse. Approximately only 1,000 transplants, but this is little bit better when compared to what it was 4 years back and 5 years back being performed, and more than a lakh of patients are in the waiting list, and the death rate is almost like 2.5 times that of United States. If you see the natural history of chronic liver disease, because of these various causes, viral infection, alcohol, NASH is a going concern, that is fatty liver-induced cirrhosis, or autoimmune disorders, cholestatic disorders, metabolic disorders, these normal liver changes into early cirrhosis, and later on goes into a full-fledged cirrhosis. And then when decompensation occurs, what happens in decompensation? Patient develops jaundice, portal hypertension, ascites, encephalopathy. Then the only option which is left over is go for a liver transplantation, or we can break this as a bridge towards liver transplantation, possibly by inducing stem cell therapy here. The median survival of a patient with compensated cirrhosis is almost like approximately around a period of around 7 to 8 years. But once decompensation starts, it was only around 1.5 years. This is the grave situation when a decompensation occurs in a pre-existing cirrhosis. You have a disordered architecture, loss of function, and aberrant, the hepatocyte regeneration takes place in somewhat. This is the prognosis factors. If there is no varices or no ascites, only 1% chances of death. But once bleeding occurs and ascites occurs, almost 57% chances of death. This is a decompensated state, and this is a compensated state. If you see the liver anatomy, if you see here, this is a central vein and this is the portal triad, and this is called as a zone 1 and the zone 3. This is very important because the nature of the restitutive response or the cellular mechanism of repair differs in these regions, because this is repaired in a different way here and repaired in a different way here. So we need to understand the anatomy of the liver very properly. These are the hepatic sinusoid, pre-sinusoidal space, which is the most defining zone here in patients with cirrhosis. If you see here a normal liver, these are the hepatocytes which are normally with microvilli and all. This is the space of DC, and we have the so-called the sinusoidal, these are the sinusoidal space, and which is lined by the endothelial cells which are fenestrated. And we have the Kupffer cells here. In this space of DC, we have so-called the stellate cells. And once any injury takes place, what happens is the Kupffer cells get activated, and by paracrine activation of stellate cells which are situated here in the space of DC, lay down the collagen fibrils, and matrix degeneration occurs, retinoid loss occurs, as well as the microvilli of the hepatocytes are lost, the sinusoids fenestration is lost. As a result, the exchange of molecules, the macromolecules or the tissue molecule, whatever the the tissue micronutrients in between the sinusoids and endothelial space is totally lost here. This is very important as well as the hepatic reserve and the so-called, if you see here in patients with acute, the hepatic reserve, in acute on chronic liver failure, the hepatic reserve is far down, it is less, but further down in patients with decompensated cirrhosis. When an injury occurs or any insult occurs, the patients with acute on chronic liver failure progressively deteriorate, and they end into so-called multi-organ failure or death. We can stop this migration into so-called, the fast downhill course in such patients by so-called ameliorating the acute injury, by modifying the patient's immune modulation to sepsis, as well as providing regenerative therapy in this period, which is called as a golden therapeutic window. Whereas in patients with decompensated cirrhosis, there is a progressive downhill course, and they land up into multi-organ failure and death. But in such patients, when compared to so-called acute on chronic liver failure, since the hepatic reserve is somewhat better when compared to decompensated cirrhosis, we can give substantial therapy here and stop the migration here to sepsis and multi-organ failure and cause recovery also by stem cell therapy. This is in the golden therapeutic window, which lasts for around 1 to 2 weeks immediately after injury. If you see what happens, this is the most defining slide. This is what we call in any patient with acute injury. Whenever an acute insult or injury because of alcohol, virus or any other drug happens, it releases lot of so-called DAMPs, which are damage-associated molecular proteins. Lots of, this activate the Kupffer cells, which are the macrophages, tissue macrophages in the liver. And once these get activated, what happens is they release lot of inflammatory mediators, cytokines, eicosanoids, as well as several lysosomal and proteolytic enzymes. And these also activate the so-called the stellate cells. These are the stellate cells. And these stellate cells, once they get activated, they release the nitrous oxide, thromboxane, A2, endothelin and all these things. Particularly this nitrous oxide is very dangerous. What it causes hepatocyte necrosis, as well as necrosis and apoptosis, as well as death of the hepatocytes, as well as this nitrous oxide can cause hepatic microvascular alterations, as a result leading into portal hypertension or increase in the portal pressure in these patients because of cirrhosis. And then what happens is the third mechanism by which these Kupffer cells get activated is by dysbiosis, or called as a leaky gut. Because of this, from the intestines, the immune cells are flushed into the liver, and they activate the Kupffer cells. Also, what happens is in these, the neutrophils which are, because of this injury, the neutrophils which are collected here, they are dysfunctional. They do not do the phagocytic functions, and they also release a lot of reactive oxygen species, which also cause hepatocyte necrosis as well as apoptosis. By these effects, what happens is continuation of acute hepatic injury, hepatocyte death, and all this leads to so-called systemic inflammatory response, as well as the CARS, which is called as compensatory anti-inflammatory response syndrome, which leading to multi-organ failure, sepsis and death in these patients. This is the disease progression, which starts with the inflammation, leads on to loss of cellular matrix and the parenchymal damage. If you can see the fibrous septae here, which between the cells they form, and in a healthy cell, the hepatocyte growth factor is on the higher side and TGF-beta is on the lower side. And when cellular damage occurs, this totally reverses, the hepatocyte growth factor decreases and the TGF-beta increases. And this is the entire sequence of events which happen in a liver cirrhosis because of liver failure. The synthetic metabolic and detoxification functions are lost. Liver failure occurs. As a result, what happens? Lot of accumulation of vasotoxins, as well as this which cause the immune dysfunction, renal dysfunction, and circulatory dysfunction, as well as cerebral dysfunction. What I mean to say is the cirrhosis is a dynamic disease having its roots and effects on several organs. And if we can, if we can give some sort of a therapy here with a regenerative potential, but particularly the stem cells, which can help in regaining the metabolic and nutritive growth factors, which will help in, shaping the liver, better way in patients with end-stage liver disease. You know quite well the cirrhosis is irreversible, with the only solution being liver transplantation. The quality of life is severely affected in both patients and caregivers, because the major problem here in India, particularly as far as liver transplantation is concerned, is because of, in addition to the cost factor, the intensity of the cost factor, non-availability of donors, operative risk, complications associated with rejection, use of immunosuppressive agents, and cost intensiveness, which I have already highlighted, we need to search for an alternative or a surrogate therapy. Stem cell therapy is a great hope for regenerating tissues, which we know quite well, and this is the latest article which people are now getting aware of it, that the stem cell therapy is a new hope for liver transplant patients. Because they have a regenerative potential, they can be highly proliferative, self-renewal, can differentiate it into desired cell types, provide functional and structural support to the failing organ, can modulate the intra and extracellular environment, and have a replicative immortality. Every organ has a repair and a regenerative capacity. Like liver, we have the induced so-called ito cells in there, but regenerative and repair problem, it differs in different organs. Repair of each is mediated by endogenous stem cells, and we, in case of liver failure, we need to activate the surviving endogenous stem cells, or we need to also augment the already existing stem cells by supply of stem cells from exogenous source. So what are the sources which are available? We have hematopoietic stem cells, mesenchymal stem cells, allogenic stem cells. We are very lucky that we have a data which we have done, which is the only center which in India we have a data of all this we have tried in liver cirrhosis patient. First was on hepatopoietic stem cells as a pilot project designed by ICMR, which we did from bone marrow, and because they have a self-renewal and differentiation capacity, and we did this and we published in 2010, and which was a pilot study we did in 4 patients, and which was found that what we did was we induced granulocyte colony stimulating factor of 5 micrograms per kg per day for 5 days, and then followed again every 4 days, and we gave around 12 injections. We also injected darbepoetin, which is also a colony stimulating factor subcutaneously, and we gave every week we gave 40 micrograms per week. And after that we removed the bone marrow, we aspirated the bone marrow, we isolated the bone marrow stem cells, and we injected in these patients. The idea behind this is that it activates the in situ mobilization of the bone marrow to the disease organ, remodeling of the extracellular matrix by increasing the HGF, by decreasing the pro-fibrotic activity of TGF-beta, improving the angiogenesis, degradation of the collagen, as well as causing liver regeneration. But it was only a pilot study, but we were not getting good results, and so we had to convert it into a mesenchymal stem cells. We looked into it, and we had a good data from that, and we did a multi-center trial on patients with alcoholic cirrhosis, a study which we had just now come out with. The data has to yet be analyzed. We have already done in 8 patients with alcoholic cirrhosis. And we isolated from bone marrow and adipose tissues, dental pulp, mesenchymal stem cells. This study was done from bone marrow, and it was able to differentiate into mesodermal lineage. We know quite well they secrete growth factors, cytokines, and chemokines. They are non-tumorigenic in nature, and they home or migrate to damaged or inflamed tissues, and hypoimmunogenic in nature, and also can inhibit immune responses. There are the various sources of mesenchymal stem cells, and they are classical that they have a CD73, a CD90, and CD105, and they are CD34 minus, negative, and these are the benefits of mesenchymal stem cells. because they can be rapidly grown in culture, because ease of isolation, and they are also, there is no risk of rejection. It can be used across the HLA barrier, and they are pluripotent and immune privileged also, and greater potency of cultured expanded product. And we can have efficient large scale expansion. Because these stem cells have, mesenchymal stem cells have immunomodulatory properties, able to regenerate and cause new hepatocytes, and also have fibrolytic activity as well as hepatic stem cells, stellate cell apoptosis. If you can see chemotactic activity, the cells, what happens is whenever a liver injury occurs, there is a lot of cytokines and chemokines which attract the mesenchymal stem cells to the site of injury by a mechanism, by a so-called a rolling and a selectin P-mediated mechanism. Particularly the rolling, these mesenchymal stem cells attach to the site of injury by these integrins VLA4 and ICAM1, and they call this is a multi-step addition and regulatory mechanism, and also they also transdifferentiate into the extracellular matrix. They get attached to the collagen and fibronectin via the so-called integrins like hyaluronidase and CD44. The effects of mesenchymal stem cells are they release a lot of soluble factors, inhibit the T cell proliferation, and also they cause inhibition of the proliferation of the dendritic cells from the monocytes. Dendritic cells are very important. Why? Because they are the cells which present the antigen to the naive T cells immediately after maturation. And proliferation of dendritic cells, they decrease the pro-inflammatory activity of dendritic cells, increase the IL-10 by making it more anti-inflammatory phenotype. They also cause inhibition of NK cell, which is a mediator of innate immunity, and also by release of this indolamine 2,3 dioxygenases, which catalyzes the conversion of tryptophan to kynurin, which inhibits the T cells proliferation. There are some multiple paracrine effects of MSC which will be effective in patients with cirrhosis. But the point is, the MSCs do not provide functional support to the damaged organ. They will be of immunomodulatory effect, having immunomodulatory effect, fibrolytic effect, pro-regenerative effect, and they will be a functional support to the already existing damaged organ by difficult to control the plasticity, function only as an immunomodulator, and we need a large number of differentiated functional cells to support. But instead, in addition to that, the reason is that functional mature hepatocytes are very, very important in all these things. So what we did was we isolated from the fetal cells, from the early second trimester, from the fetuses, spontaneously aborted fetuses, we took out these cells and we isolated the hepatocyte progenitor cells, which are having positive for EpCAM, that is CD326, alpha-fetoprotein, albumin. Albumin, a marker of synthesis, alpha-fetoprotein is a marker of maturation, and CD326 is a marker of integrity, cell integrity. And these cells are having a high proliferation activity, less immunogenic, more resistant to ischemic injury and cryopreservation, and could augment the significant engraftment within the recipient liver, and they were giving rise to functionally identical cells. This was the isolated hepatic progenitor cells. In day 7, it was committed hepatic progenitor cells, and we could have a heap of colonies of hepatic progenitor cells. And these were identified by physical methods, sorting, and phenotypic markers, which I have already told, and they were negative for CD45, which is a marker for blood, blood progenitors. This was papers which we have published, in which we enriched also by using flow cytometry and magnetic sorting. And we also saw that these cells were hypoimmunogenic, that is, their HLA class 2 expression was negligible in patients, in EpCAM positive, that is what we call the hepatic progenitor, fetal hepatic progenitor cells. These were the reproducibility, which were the criteria which we used. The viability was checked by trypan blue, albumin production, and then urea cycle enzyme also was used as a measure of the functional viability. And then we have also published this in Transplantation Journal. And we have tried several routes wherein we injected these cells, but the most accepted site is by a Seldinger technique, by hepatic. We inject through the femoral artery, go into the hepatic artery, where it branches out from the celiac artery, and go into the hepatic artery, and then inject the cells here. We tried actually into portal vein, intrasplenic, but they were very invasive. And as you know, cirrhosis patients are very sick, and we need to give them, because they have other features like ascites, coagulopathy, which we need to manage, and it would be a big burden on the clinician if you use very invasive procedures. In patients, when we infuse these stem cells, this is what the description of this. What happens is, when the liver cells get damaged, they release lot of so-called cytokines and chemokines, the SDF1, HGF1, SCF, which these act on the receptors on the stem cells, particularly this CXCF4, CMET, and CKIT respectively. And also MMN, that is metallic proteinases 9, which also are released from the tissue damage, also recruit these stem cells to the site of injury. When we inject these stem cells, what happens is, the descriptive mechanism which has been proposed is that when they reach the portal blood, they almost like, when they reach this portal blood, what happens is that almost phagocytosis occurs and cell loss occurs up to around 70 to 80%. And then once they enter into the, what happens is that the pass through the hepatic sinusoids into the endothelial cells by release of vascular endothelial growth factors, and also by disruption of the gap junctions. And once they enter into the hepatic, so-called penetration of the parenchyma, then later on what happens is cell integration, cell implantation, and cell proliferation takes place by release of these hepatocyte growth factors, TGF, as well as the fibroblastic growth factor, which also would be helping in stabilizing these cells and cause so-called subsequent proliferation. The idea behind is to these bone marrow cells as well as the progenitor cells, when they go in, they would be breaking down they would be stopping the cascade of reactions which are already told inside, the subsequent mechanisms which have already been told. We have already reported in 2010 multiple cases of 6 months follow-up. All the procedures were safely performed without any specific side effects, and all the patients, there was improvement in some, observed in terms of appetite, constitutional symptoms improved, decrease in edema feed, reduction in ascites, reduction in diuretic requirement, reduction in recurrent admissions into the hospital for getting a large volume paracentesis or repeated attacks of encephalopathy, no episodes of varicose bleeding or fever and encephalopathy in patients with end-stage liver disease. These are the liver function tests which were monitored over a period of 6 months, and we are definitely showing a improvement in these patients. The idea behind this is that whenever a patient with end-stage liver disease comes, we calculate the model for end-stage liver disease score, which is a score which we identify by which that if the score is more than 40, the 100% chance of mortality. MELD score between 31 to 39, 83% chance of mortality. MELD score between 20 to 30, 76% chance of mortality. Between 10 to 19, 27%. And if the score is less than 10, 4% chance of mortality. So what I propose here is, by giving this stem cell therapy in patients with end-stage liver disease, those who are waiting for liver transplantation because of several reasons, because of shortage of donors, because of several comorbidity conditions, we can achieve the decrease in the MELD score by giving them a prolonged life in such patients. Those who have, even those patients, we receive a lot of patients who are denied liver transplantation because of their advanced liver disease and because of their poor outcome results after spending such a large amount of money for a liver transplant. Since the patients are being sent, we can offer them an alternative, a compassionate or a surrogate therapy. Sample, this is the retrospective study which was relevance of lowering the MELD score by even a few points demonstrated a reduction. It was also improved the so-called morbidity in such patients. We also did a 2 years analysis, and we have out of 25 patients, only 10 were in regular follow-up for 2 years, from 2010 to 2012. 3 patients were in class 1, 4 patients in class 2, and 3 patients in class 3. And we found that the MELD scores were almost like, they were in class 1, they were showing a decrease. In other classes, they were definitely showing a decrease, but it was not coming down to such an extent. But it was stabilized. This was again a 1 year, 3 year, and 5 year follow-up. this was published in the last year's World Journal of Stem Cells, a viable approach for the treatment of liver cirrhosis. And we also did a CT scan analysis of patients to know whether these stem cells can cause any, possibility of the doubt of a tumor, or, it can cause a teratoma. But we have seen that after 6 months in same patient, 1 year, there was no signs of tumor. And there was also a doubt whether this could cause, when we inject into the hepatic artery, it would cause any thrombosis or ischemia or narrowing of the hepatic arteries. But later on, we found that in same patients, 6 months later, there was the patency of the hepatic arteries were analyzed, were same. So we need to do an analysis wherein we need to stratify these patients, and we need to come out with a double-blind, placebo-controlled, a trial wherein we can combine both the granulocyte colonase eliminating factor as well as the mesenchymal stem cells as well as the hepatic progenitor cells, which would be a tailoring of therapy, like when we have to counter the immunomodulatory fibrolytic effects as well as the functional hepatocytes. If they are being supported, then the chances of this functioning of liver in such patients would be very high. The things to consider before designing a stem cell therapy is to prognosticate and prioritize the patient, type of stem cells to be delivered, doses of stem cells, tools of cell delivery, site of delivery, and also a compassionate therapy. Integration site of transplanted stem cells, engraftment, that is a major where the cells, when we are injecting the stem cells, where are they going and residing in, and what are the functions they are doing, and what are the fate of the transplanted stem cells. We also do a lot of fibrosis, where there is a non-invasive assessment of fibrosis in these patients, whether this fibrosis is coming down by a fibroscan and other indirect methods. These are the challenges in the stem cell transplantation, and particularly we are looking into several methods. That is, we injected, what we did was in these patients we labeled the cells with HMPAO, hexamethyl propylenamine oxime, and we did a scintigraphy immediately after, and we could find that the stem cells were localizing homogeneously in the liver in 24 hours in the same patient when they were labeled with HMPAO by nuclear scintigraphy. They were equally distributing and homing there. And we went on, but after 24 hours, we were not able to find out later on what is happening to the stem cells. So we went in and then we did an animal experiment. We injected DID labeled EpCAM cells intrahepatically into mice, and we found that with Kodak's FX PRO imaging, we found that the cells were imaged at various points, that is day 1, day 10, and we could find up to around 110 days post-transplantation these cells getting localized into the liver in animals. But human beings, we were not able to combine this dye because we were not sure whether this dye would be toxic or would be causing any later on problems to the kidney. So now we are looking into nanoparticles. As you know, this nanoparticle is the smallest unit of an object that behaves as a whole unit with respect to its transport and proteins. We are using nanoparticles which are indigenously designed by 1 to 100 nanometers. We combined it with gadolinium and iron. As you know, gadolinium is being used in MRI scans. We did this is the scanning electron microscopy and transmission electron microscopy, and we found that these nanoparticles could be internalized inside the cells, and we can also internalize these as optical rings, as you can find here, and also these rings inside the cell once the images around, and they can be found out in both light microscope as well as in transmission electron microscopy. We injected into the tail vein, into the portal vein of the mice, and these cells were localized, and we also did a MRI imaging, and this is MRI imaging of this, and these were found in liver, spleen, kidneys, and nucleus chordatus in T1 and T2 images. We wanted to know whether this GDFIO, that is the gadolinium iron, what is the distribution and uptake and clearance from the biological systems, and we found that it was rapidly decreasing. It was not getting concentrated, it was not causing any problem to the patient. The present study shows that the safety and feasibility of these nanoparticles, but we need to, it has a great potential for reaching new prospects in regenerative medicine and stem cell therapeutic potential. To summarize, these, as you know, the wonder cells, what you call as the mesenchymal stem cells, they are receiving enormous attention in regenerative medicine, tissue protection, graft enhancement, and immunomodulation. They are ideal potential stem cells for therapeutic application because of their safety and easily available sources. Diagnosis of liver fibrosis at an early stage and prevention of its progresses to cirrhosis is a challenge in the management. Organ-specific adult stem cells are ideal in compensating the functional loss of organ, but the major limitation is the source. Combination of MSCs, having a immunomodulator, so-called fibrolytic effects, pro-regenerative effects, and hepatic progenitor cells, by which we can functionally compensate the liver in liver cirrhosis, is a major challenge. Supportive and adjunctive therapy is a bridge towards liver transplantation. We need to have a dedicated centers wherein we need to have improvement in delivery techniques, engraftment of transplanted cells, tools for biomarkers for tracking of transplanted cells. Can this be used in repopulating the decellularized organ is emerging as a potential and area of organogenesis. And we need to have an integrated team approach between researchers and clinicians, dedicated specialized centers, preparation and delivery of cells under one roof, and strict adherence to the new stem cell regulatory framework. This work was entirely done by the team of CLRD, and I dedicate my entire talk to my teacher, my father, Professor Habibullah, who we call him as the father of stem cells hepatic stem cells in India. He was the one who introduced me to the fascinating field of regenerative medicine and molecular biology. Thank you so much.
Thank you. It was an extremely exciting talk. I will actually challenge your assertion that your presentation doesn't fit into this topic and say that I think it integrates very nicely. We're actually working on the combination of photobiomodulation and retinal stem cells. And so I think that the potential to put these together is profound. Perhaps even the ability, can you take mesenchymal stem cells and essentially partially differentiate them into progenitor cells so that you don't necessarily have to have a fetal source, and then use those to repopulate the liver? Is that possible, or is it just too many cells to grow over too long a period of time?
Absolutely, that's a great question. See, the issue is that, as you know, the liver, when it is under tremendous stress because of several things, reactive oxygen species, mitochondrial stress, ongoing hepatic injury which is going on because of flush of inflammatory mediators and cytokines. Any therapy which can retard the progression to cirrhosis, that is progression to fibrosis, would be welcome. A combination of a photodynamic therapy, combination of mesenchymal stem cells with a tissue-specific hepatic progenitor cells would be ideal, would be the future, I would say, in these patients with end-stage liver disease, who are patients who are in dire need of liver transplantation, but this could be acting as a bridge in lowering the MELD scores, prolonging the, stopping the so-called the disease to flare up, and making the patients viable for a liver transplantation at a later date when they occur.
Right. It would actually be nice if you could basically repopulate the liver.
Yes, exactly. That repopulation, what you said, was on patients with acute liver failure. That is the challenge, actually. We are also, actually, my talk was on cirrhosis. Actually, I have another set of preparation for another set of slides which are dedicated for acute liver failure, wherein we did, we did a completely decellularized in goat liver cells, as well as in, we again repopulated the entire, the liver, so-called the microvasculature, everything which is there inside the skeleton, so-called the cytoskeleton, by the hepatic progenitor cells as well as the mesenchymal stem cells.
This is brilliant work. I think this is really, it's critical. All over the world, it's critical in terms of the need for various transplants. And you've certainly moved it very far forward in terms of the hepatic liver disease, which is a huge problem clearly in this country and also a major problem all over the world. Thank you.
Absolutely, absolutely.
Yeah, so it was a very good talk, actually. So I mean, you correctly identified the big problem with mesenchymal stem cells is whether they get engrafted and even more long-term permanent survival in the organ they're sent to. And there's remarkably little evidence that this actually ever happens, and maybe none. I mean, it's not my field. And your study in the mice was interesting. I mean, there's a lot of things you could have done differently, right? First of all, you use skid mice with no immune system, so you can engraft anything into them. The idea about mesenchymal stem cells, as you said, they have very low MHC expression, they don't express antigens, so you can kind of do what you like with them. But once they differentiate, that all changes. The HLA comes back, the antigens come back, and they become as immunogenic as normal sort of somatic cells. And, this is clearly the big problem with mesenchymal stem cells, is they're fine in their stem state, but once they differentiate, they get rejected. So I would suggest the right experiment to do in mice is to take a different strain of mice, let us say C57 black 6, where the whole mouse expresses green fluorescent protein in every cell, right, including the liver. So you isolate the liver stem cells from a GFP C57 black 6 mice, and then you transfuse it or inject it or whatever you do into a bulb C mice, both immunocompetent, and just see if the GFP cells survive in the liver long term. It's a relatively easy experiment to do, and I don't know if anybody's ever done it, but it's crying out to be done just to show that these cells can survive long term in the liver.
Yeah, my take on this is that since the experiment which we had done was on hepatic progenitor cells from the fetus, what we did was we tagged them with the nanoparticles, and we injected them into the skid mice, and they were not mesenchymal stem cells. We wanted to see how these cells are getting, what is the fate of these transplanted cells in a skid mice. But actually we are now proposing a clinical trial wherein we want to know because we have already done and published enormous data which is there in the peer-reviewed journals in patients who are end-stage liver disease. They were infused with so-called fetal liver cells. Now, what is happening to the fetal liver cells? Are they getting implanted? Are they getting transplanted? Are they getting proliferating? What is happening to the fate, as I said? So we wanted to combine this and then see to it that these cells are, when they are injected into the mice, their uptake should be good, the distribution should be good, the clearance of this, because we are having an iron as well as a gadolinium particle attached to it. So is it getting stayed back into the liver, kidneys, spleen, heart, and all these organs for a very long time? Before we want to get into a clinical experiment, we want to see how they are into a skid mice. That's the reason why we did into a skid mice, the first experiment. So we want to translate this now into a clinical. What is your take on this actually?
Obviously a lot of mesenchymal stem cell therapy, various other stem cell therapy works fine. And, you put a lot of reasons why it should work. They're immunomodulatory, they're anti-inflammatory, they secrete a lot of growth factors and cytokines. So they're good things, and, that's why there's buckets of papers out there on why this stem cell therapy works. But the hard evidence that the stem cells get engrafted and survive long-term over many, many cell generations is like nothing, probably nothing. And the reason is because when the cells differentiate, they get rejected by the immune system. So autologous stem cells are different, okay? Take them, from the bone marrow or from the fat of the person, they put them back in the person, they're not going to get rejected. I don't know what the evidence is that they survive long-term either, but
the problem with the autologous bone marrow stem cells in patients with end-stage liver disease is these patients are very sick. In order to take out the blood from the so-called bone marrow, aspirate from such a sick patient from the iliac crest it is a gigantic proposition. Because they have coagulopathy, they have ascites, they have jaundice accompanying them. They have, on top of it, they have encephalopathy. So that is the reason why possibly, and the cells which we isolate from the autologous bone marrow and then later on transfuse them into the same patient. They are, when we isolate them and when we differentiate them, the cells which we are getting out are little in quantity when compared to the mesenchymal stem cells as well as the hepatic progenitor cells. The difference, as you said, hepatic progenitor cells are going to augment or they are going to supplement the functional hepatocytes. They are just going to increase the hepatocyte level, hepatocyte quantity or the hepatocyte so-called numbers in the failing liver. Mesenchymal stem cells, immunomodulatory, antifibrotic, as well as the pro-regenerative capacities, chemotactic, and all those things. Whereas the hematopoietic stem cells, they are only going to play with the growth factors. That is, increasing the HGF, decreasing the SDF, and thereby giving them an internal milieu wherein also they would be actively responsible for stimulating the resident ito cells which are there inside the liver to stimulate them and cause regeneration. You would just pump in, and that is the idea of giving the so-called granulocyte colony stimulating factor. There are a lot of papers which are coming out from a center in Delhi, that is ILBS, wherein they propose no need for even giving autologous bone marrow. These patients just should be given only GCSF. That would be mobilizing the bone marrow cells into the liver, thereby causing the growth factors to get elevated.
And as Uri Aron has shown, if you use photobiomodulation on the long bones, like the shin bones for instance, you can mobilize autologous stem cells from the bone marrow, and they'll go and repair the heart and the brain, and for all I know, they'll go and repair the liver. I mean, it's sort of worth trying.
Yeah, that's a point take. Thank you, sir. Yeah.
I think maybe another approach, I don't know if you've looked at this at all, would be induced pluripotent stem cells. If the skin cells of these individuals are healthy enough for you to actually take it through the induced pluripotent process, and then you don't have the rejection problem, then you differentiate them into liver cells, ask them to become liver cells or progenitor cells, and return them. It probably depends on the general health of every cell in the body, but it does get you past the rejection aspect of it. The other thing, and maybe we should talk during the break, is we've been doing some work in induced pluripotent stem cell populations in the retina, and actually looking at one of the, as I said in my talk yesterday, mitochondria determine everything, and I maintain they determine the health of stem cells and the differentiation potential. So they'll move them towards differentiation. And if you make that stem cell colony or that progenitor colony healthier, it is more likely to survive implantation. And we're testing this hypothesis now in retinal disease. I think it's probably worth looking at both experimentally and clinically, and clearly your work bridges both concepts. I've actually looked at your excellent paper in the World Journal of Stem Cells.
Yes.
So thank you very much.
Thank you.
I would suggest, you spoke about photobiomodulation and using maybe light to support stem cell surviving and homing and differentiating. And what Michael Hamlin said yesterday, we spoke about the studies by only irradiating the bone marrow, and showing repair of heart and kidney and everything. That's such amazing. So I would my proposal is we have some old studies already from Russia, maybe 20, 30 years ago, using the first intravenous lasers on chronic hepatitis and even liver fibrosis and cirrhosis with excellent results. So what I would suggest, and after our experimental experience, I would give the stem cells maybe intravenously only, maybe in the artery also, what you did already, and keep them alive. Give them energy by intravenous laser. The red laser brings better viscosity of the blood. The green laser intravenously brings better oxygen availability.
Yes.
Blue laser brings more nitric oxide in the blood, which also supports stem cell survival and differentiation. We know this, and there are already some nice studies about this. And this is such an easy method. You know, you have the needle in the vein and inject the stem cells, and I think this could be a great support after our experience.
Thank you, sir.
Actually, that's true, because in end-stage liver disease, where they are already decompensated, there is good evidence to show that intravenous infusions of mesenchymal cells help. It's obviously not going to regenerate the liver, but the MELD scores do fall down. We have seen it in our experience. The MELD scores recover, and patient gets better. Obviously, it's not a replacement for liver transplant, but in your condition where you're talking about patients waiting for a liver transplant, this is an ideal scenario where you can treat them with this, and it's very simple because you just do intravenous infusions and there's nothing much to do about it. And there's no worry about differentiation and rejection or anything of that sort. You're only looking at inflammatory, anti-inflammatory and immunomodulatory properties of the mesenchymal.
Thank you, sir.
Thank you very much, Dr. Habib. That was a very interesting presentation, and I think leaves a lot of scope for integration of photobiomodulation with what you do. Good. I would now like to invite Dr. Nicholas Weiss, who is a practicing chiropractor for 16 years and currently a postdoctorate research fellow at the University of North Carolina. He is a board member of the North American Association of Laser Technology, Laser Therapy, and was instrumental also in having the recognition and popularizing chiropractic therapy profession in India. He had an installation a few years ago in Ahmedabad, a clinical installation, which I think he's wound up in the last couple of years. And today, he's going to introduce to us the unusual application of low-level laser therapy, which could be a real eye-opener. Welcome, sir.
Yes. That's good. Good afternoon, everyone. First, I'd like to thank the organizing committee of this wonderful conference, especially Dr. Murthy and the members of the IALT. It's an honor to be presenting on this stage with some of my research heroes and esteemed members of the laser community. I feel a bit sometimes out of place at these types of mechanistic, heavy scientific conferences, and I feel a bit like I come telling tales of the great beyond, of strange and wonderful stories of laser therapy. And so I offer this to you to do with what you will, and we can argue about it later as to some of the mechanisms and things like that. But so first, I'd like to start with just an idea. One of the most important ideas, I think, in healthcare, when it comes to any modality that you should choose to do for a patient, that sometimes it's best to do as little as possible. in a theme of a conference where we're studying the effect of light and the concept of regenerative medicine. I think something that's come up again is that sometimes the best results come when we can induce the body to heal itself. And that's one of the beautiful things about PBM and the effect of light and the induction of creation of our own stem cells. So this is truly a wondrous tool, and I would like to take a bit of a detour before I talk about my application of laser therapy. It became apparent to me that some of you may not know very much about chiropractic. So I've been a practicing chiropractor for 16 years now. In the United States and in North America, United States and Canada, chiropractic is considered the largest complementary and alternative medicine field, second only to medicine and dentistry. It is utilized by approximately anywhere from 8.5% to 11% of the population. So it's certainly one of the more popular integrative medicine therapies. The profession is established. When I first made this slide, it was 81 countries. And due to the work that we did here in India, we were able to make it 82 countries. And so chiropractic is now recognized as an established profession here in India. Reason why this is important, certainly for researchers and for manufacturers of laser devices, chiropractors were some of the earliest adopters of laser therapy in the United States. It was certainly popularized in the early 80s, which, we have, certainly the use of laser therapy and chiropractic and in acupuncture from very early on, certainly in advance of mainstream medicine. So this document, this is just a little bit of history. I was involved in a project that our mission was to get chiropractic recognized here in India, and so this is a letter from Dr. Nirmal Ganguly, who is the longtime head of the ICMR, the Indian Council on Medical Research, and he basically, we made lots of trips over here and lots of presentations at Parliament and in New Delhi, in the top levels of the government, and we were successful at getting chiropractic recognized here in this country. So it was very kind of an amazing feat given the state of bureaucracy and the difficulty and the speed at which things usually move. So within 5 years, we were successful from start to finish of getting chiropractic recognized. So after that, I was involved in opening a clinic here in Ahmedabad, where we were treating hundreds of patients every week with chiropractic and laser therapy. These were some influential members of parliament. Jivabai Patel from Gujarat. This is a wonderful guru from Ahmedabad named Kanu Dadaji Bhagwan. And he came to our clinic and gave us a blessing. And it was really quite a fantastic time. So very briefly, chiropractic is a healthcare discipline which emphasizes the inherent recuperative power of the body to heal itself, much in the way that laser therapy induces the body to make changes, to improve its function, and that's, in some sense, that's the only way that healing occurs. We're always trying to induce the body to heal itself. Early on in my practice, I discovered that PBMT was a fantastic tool to aid this process. There are just some, basic principles of chiropractic. One of the main things is that structure equals function. The alignment of your spine can affect the functioning of your nervous system. It can affect the central nervous system as well as the autonomic nervous system. And we have, by way of affecting the spine, we have pathways that can affect the autonomic nervous system, and even cycles of inflammation and the immune system function. So chiropractors accomplish this through a number of methods, but the primary method is manipulation of the spine. Chiropractic has been shown to be quite efficacious for musculoskeletal conditions. From the Spine Journal, a very prestigious orthopedic journal, we had a big study showing that it was 5 times more effective than NSAIDs for the treatment of chronic neck and low back pain. A Cochrane systematic review showed that mobilization and or manipulation when used with exercise are beneficial for persistent mechanical neck pain with or without headache. Interestingly enough, they also mention low-level laser therapy as a supported therapy with significant evidence, no doubt because of the work of Dr. Chow. So we've seen similar slides to this in other people's presentations for the treatment of for applications for low-level laser therapy. You'll see that they're pretty much the same thing. We have the whole array of musculoskeletal conditions. This is why people seek treatment. 75% of all visits to any practitioner in the United States are due to musculoskeletal conditions. Low back pain, neck pain, headaches being the top 3, and the other reason in the top 4 would be psychological reasons, depression and anxiety. So musculoskeletal pain, this is what drives the vast majority of healthcare visits and healthcare spending. So some of the people in the audience may recognize this. This is a very nice paper that outlines the evidence, the state of the evidence for the use of laser therapy in musculoskeletal pain. So I offer to you that the combination of manual therapy plus laser therapy is a powerful thing indeed. This was a study that was published in the Journal of Physiological Therapeutics, which is the top chiropractic journal, and they compared 3 groups. One was chiropractic manipulation for neck pain, second group was low-level laser therapy for neck pain, and the third was combination. So this was not placebo or controlled, but what they found was definitely a synergistic effect between the manual therapy and the laser therapy. So that all of the groups improved significantly, clinically, 2 points on the VAS scale, but the combination of manual therapy plus laser therapy caused a significant increase above and beyond just either as a monotherapy. So this is something that I found very early on in practice, and so this became a cornerstone of what I did for my patients. So this is a little historical slide. I believe this is some of the first early human trials on laser therapy. Perhaps Andre Mester, I'm not exactly sure where and when this was taken, in what underground lab or lair this was taken, but anyway. Okay, so that's a bit of an introduction to chiropractic. The next segment I offer to you as a bit of a detour, perhaps, into the unknown, and you can put on your tinfoil hats along with me, if you like, and we will look at this thing that I developed starting in 2007. So I'd like to introduce you to an unusual application of a low-level laser that I call CLRT, cranial laser reflex technique, which combines the principles of laser acupuncture with a different map. A map that was discovered by chiropractors in the early part of the 20th century, and is a system of points and lines all over the cranium. The first map that I discovered was a system of points that seemed to connect and control every major muscle, specifically the tension of the muscle and also the pain sensitivity in that muscle. Later on, I discovered a system of points that seemed to connect to every single segment of the spine. And these are, so the muscle points came from chiropractors who were doing applied kinesiology, and the spinal points came from Dr. David Denton. Having done this on tens of thousands of people at this point, and having taught this to hundreds and perhaps thousands of practitioners, these are some of the device specifications that I have used personally and have gotten results with, some of which may seem counterintuitive. I have used wavelengths that are not supposed to penetrate the skin more than a few millimeters. So I've used violet, blue, green, red, and infrared wavelengths with similar results. I've used powers as low as 5 milliwatts and all the way up to 500 milliwatts. I've actually used lasers, class 4 lasers stronger than that, but this is general range of more common applications. And the treatment times that I would often use would be in the seconds to a few minutes. Some of the points look like this. We can see that the spinal points follow cranial sutures. The muscle points are all over the skull. There's a few more slides. This is the location of the lumbar spine. It happens to be on the sagittal suture. For the knee, these are all lower extremity muscle points. And so now I'd like to show you a couple of cases that defied my understanding of what is possible in the use of lasers. So this was the very first case that excited me and where I realized that this was something quite unusual. This was a case of a post-stroke muscle spasm, where the patient presented with a grade 4 on the Ashworth scale of muscle spasm, where the angle of his arm was approximately 35 or 40 degrees. Long history of failed treatments, including Botox and physical therapy, stretching maneuvers, none of which worked, and all of which were quite frustrating and painful. I initially did a chiropractic adjustment, C5, direct nerve connection to the biceps brachii by way of the medial nerve. After I adjusted his cervical spine, there was some noticeable relaxation in his arm. Not huge, but noticeable. Slightly better, slightly less tense. And then I used the laser on his forehead, specifically on a cranial reflex, a horizontal line in the middle of his forehead. It's for the biceps brachii. So this is not the picture from the first treatment. This was post after the second treatment. But within 60 seconds of literally shining a laser in this fashion on his forehead, his arm started to quiver, started to fall. To about here. 135 degrees. If this is 90, to about here. 1 minute of treatment. This was not what I expected to happen. I didn't know what was going to happen. This was, as you can imagine, quite eye-opening to me and quite remarkable. The second time he came in, 3 days later, this is what he looked like. The arm had drawn up a little bit, but certainly not to the full extent that it was. We did it again. This time, his arm became fully relaxed. We kept doing it over the course of a couple of weeks. Every 3 days, his arm would draw up a tiny bit and relax even further. After 2 months of a total of, I would say, 12, 14 treatments, something like that, his arm became, I won't use permanently, but it became continually relaxed with an uncurling of his fingers. some limited function, not a tremendous amount of function returned, but certainly a much more comfortable position for his arm, and he was now able to drive, dress himself, and wash himself. So this was the very first time that I used this on a stroke patient. There were many after this. This is Kim. Her spasm was there for 3 years. Again, long history of ineffective treatments. Did the same thing. Actually took a little bit longer this time. It took, not 1 minute. It took several minutes. But this is what happened immediately afterwards. Again, this was more relaxed, more lengthened than she had been in years. This is one of my favorite patients from our clinic in Ahmedabad. This is Anjali. She was actually paralyzed from age 3. She was nonverbal and unable to walk, unable to feed herself. On the third, she spoke and said thank you. Here she is on her 4th visit where she's walking with some assistance. This was a combination of chiropractic and doing the cranial technique that I just showed you. Again, remarkable cases. And it's hard to say that this would work on everyone, and I can't say that. I don't think it will work on everyone, but I'm showing you some of the highlights that we had here. Very briefly, I'm going to go over a double-blinded RCT that I did in practice several years ago, where I had, where the aim was to compare the short-term effects, didn't follow them out for any period of time, but just the immediate effects, acute effects of cranial laser treatment on a variety of different musculoskeletal pain. At 57 participants that were randomized to either the sham or the treatment group, found painful trigger points, used a digital pressure algometer to get a pain rating on the numerical pain rating scale, on the scale of 0 to 10. True laser or sham laser was applied to their head using a device that was 50 milliwatts and 810 nanometers for a maximum of 1 minute on the cranial reflex point. The initial amount of pressure that elicited a pain response was given to the exact same spot, which still had the pressure mark from the first time that we applied it. And in the control group, there was virtually no change. And in the treatment group, there was improvement in most everyone with an average of about 50% reduction in pain severity. So that was the past. And now I'm going to veer off into some future directions that I am developing studies at UNC. And a little disclaimer: these are presented. What I'm about to show you is presented as more clinical data. This has not been published yet. But first, I'm going to build a little bit of a story, a little bit of a case for why this might work. So, you may or may not be aware that chronic stress is a serious problem. According to the American Psychological Association, 22% of Americans reported extreme levels of stress, with 44% saying that their stress was going up. Whether or not this correlates to other countries directly remains to be seen, but I think my personal opinion is that chronic stress is almost a universal condition. The effects of chronic stress are well documented. Some of them are hormonal, some of them are endocrine, some of them are immune system related, but chronic stress changes the architecture of your brain. Stress weakens the prefrontal networks, and it leads to what they call molecular insults to higher cognition. And guess how quickly it happens? within 3 days. Oops. Significant reduction in hippocampal volumes in stressed animals, okay, so this is an animal study, relative to their unstressed counterparts as early as the 3rd day of stress. It doesn't take much. Now, if I recall my experience with chronic stress, I've had a heck of a lot more than 3 days. And I think that is probably true for most people. So, stress is a major problem driving accelerated aging, inflammation, decreased immune function, increased nociception and pain. So we have tremendous cascades of physiological responses due to the effects of stress. So if we could find a non-invasive, non-pharmacological treatment for stress at its source, that would be pretty interesting, I think. So, and I think we have this at our fingertips. So this is, again, now this is shifting gears a little bit. This is no longer talking about cranial reflex points. This is the idea of direct application of low-level laser light, or the application of laser therapy to the cranium to directly or indirectly affect cortical function, affect brain function. There is not I would say, a tremendous amount of evidence, but it's growing. And many people in this room are contributing to this body of work. And to me, this is the exciting stuff. We're showing that there's decrease in excitatory neurotransmitters, improved motor recovery after stroke. We've had talks already on transcranial laser, and so this is just some of the highlights. But we're getting some pretty interesting responses in animals. In humans, we're seeing effects in cognitive function and emotions. So we're drifting away from musculoskeletal. We're talking about perhaps psychological and mental conditions now. Improved motor recovery, reduced recovery time after TBI, improved sleep, progression of dementia, and then this last one, or these last two, improved functional connectivity and cortical excitability. So this was what got me started. And there's not a tremendous, I'll be honest, there's not a tremendous amount of studies supporting this, but there are a couple, literally a couple. And here they are. We have some little bit of evidence to show that transcranial laser therapy has primarily an inhibitory effect. Whether it is because of direct inhibition of cortical areas or stimulation of inner neurons which are naturally inhibitory remains to be seen. But we have a couple of studies here showing that in combination or using motor-evoked potentials with transcranial magnetic stimulation to evoke motor-evoked potentials, they're showing a reduction of excitability in the cortical areas. And here's another one showing very similar response. So in this study, we provide further evidence that transcranial near-infrared stimulation is suitable as a tool for influencing cortical excitability and activity in the healthy human brain. And the direction of effect is usually down. So, just throw this in here as potential mechanism of chronic pain. Chronic pain, it's very possible, and it's very likely, that there is evidence of motor cortex disinhibition in chronic pain populations. So we know that chronic pain changes the brain. The brain rewires to become more efficient at the pain pathways. And so there is this disinhibition and an increase in excitability in chronic pain patients. More pronounced in populations with neuropathic pain. And showing a relationship between chronic pain and motor cortex excitability. So I present this just to build a case as to why what I'm about to show you might work. Here's another piece of the puzzle. A few fMRI studies have shown that males and females have different brain responses to stress. In males, they're seeing an activity in the right prefrontal cortex area, specifically the right orbital prefrontal cortex area. In females, the right amygdala. Now, there are many papers outlining hemispheric laterality in control of the autonomic nervous system. It's a bit simplistic to say that it's 100%, because there is crossover. But the right side of your brain primarily drives sympathetic activity, stress response, fight or flight, pro-inflammatory, pro-pain, not the gas, but pro-pain. The left side, when it is active, primarily drives parasympathetic activity. The right side of your prefrontal cortex, when it's activated or hyperactive, is greatly associated with negative valence, depression, anxiety, withdrawal. All of these, in many psychological studies, have shown a preponderance of evidence for right-sided activity. As you can imagine, balance is key. When we have a dominant right side activity, that drives the sympathetic nervous system, and we end up with a dysautonomic state. We end up with dominance of the sympathetic nervous system, leading to the effects of chronic stress. So this is my treatment area. This is the target area, the right orbital prefrontal cortex in males. So this is a study that I am in pre-production for. So I'm just presenting this as something that perhaps at the next conference in India I will be showing you the results. But here's the idea. We're looking at heart rate variability and EEG. Heart rate variability is a measurement of the autonomic nervous system. EEG gives an insight into central mechanisms, central nervous system. Heart rate variability is controlled by the autonomic nervous system, which is controlled by the central nervous system, the central autonomic network, of which the prefrontal cortex and the limbic system are prime contributors to this central autonomic network. Stress produces hyperactivity in the right, specifically orbital prefrontal cortex in males, and the right amygdala in females. Transcranial PBM might possibly decrease cortical excitability or increase inhibition. Theoretically, sticking a laser on your head might possibly decrease that hyperactivity, leading to a balance of the hemispheres, decreasing your sympathetic tone, leading to an increase in parasympathetic tone, which leads to many, many downstream cascades of endocrine immune system responses affecting pain, psychological, and physical issues. So this is the premise. Recruiting 48 healthy subjects, recording baseline resting state, eyes open, heart rate variability, and EEG for 5 minutes, applying a relatively small amount of laser light to an area on the forehead which corresponds to, in the 1020 EEG system, to about the FP2 area, which is essentially right in the middle, right above the right eyebrow, for a few minutes, delivering, depending on depending on the transmittance, something approximately like this. I'm still playing with the amount of time, dosage, and parameters, so input in that is certainly welcome from the experts. And then recording post-laser heart rate variability and EEG, and essentially seeing what happens. The device that I've been using, since very interesting to most people, it's a 808 nanometer, 110 milliwatt device with a beam size of approximately 3 square centimeters, targeting this area right here for this amount of time, and that's the approximate dose. Now, for those of you not familiar with heart rate variability, it is a fairly well-established method of looking at the autonomic nervous system, and I'll give you just the very, very briefest overview of what the important factors that we're looking at. First off, increased variability is a good thing. The more metronomic your heartbeat is, the more regular it is, the less healthy you are. That is shown to be associated with many, many, many pathologies, cardiac and non-cardiac pathologies. So the more irregular your heartbeat is, the healthier it is. The more chaotic it is, the healthier it is. This is heart rate variability. There's different ways of analyzing heart rate variability. There's time measurement, where we look at these factors over a sequence of time, or we look at the frequency domain. So this is what I'm specifically interested in. The important things to look at is this and this. So in the frequency domain, low frequency is a combination of sympathetic and parasympathetic. It's not purely sympathetic. It gives an idea about sympathetic tone, but it's not 100% pure. High frequency, or RSA, is pure parasympathetic cardiac vagal output. So this is a very clean measurement right here. If you increase high frequency, or RSA, that is a good thing. There are many studies on the effects of exercise on RSA, meditation, RSA, sleep on RSA. So there are many, many, many different modalities and interventions are studied looking at this, and then the ratio of low frequency to high frequency. So this gives an idea about the balance of the tone. So this is an example of the subjects that I'm running in my clinic. So the main things to look at here is that, so we did 2 different positions. Heart rate variability can be affected by whether you're supine or seated or standing. So we did a couple of different positions here. The main things to look at are the number 1 bar and number 4 bar, because this is what the protocol will be. It will be seated, pre, seated, post. This is the logarithmic scale of high frequency. So this is baseline. This is the intervention. This is the laser on the head. So this is the measure of high frequency while the laser is on. And this is high frequency in the 5 minutes after laser therapy in the right orbital prefrontal cortex area. So we're seeing a dramatic increase. The experts at my university that I consult, that are the world experts in heart rate variability, are telling me that 0.5 units logarithmic change, that's a very significant change. And we're seeing something on the order of a full unit change. So when I showed this to the heart rate variability experts, their eyes get very big. They're not used to seeing this kind of change, even with 8 weeks of meditation. This is the heart period, which is inverse of the heart rate. So we see that the heart period, which is the distance between the heartbeats, we see that going up, which means that the heart rate is slowing down. And so again, comparing 1 to 4, we see that there is a significant increase in the heart period, which means that the heart rate is going down. In the last couple slides, this is perhaps, so this is pre-treatment heart EEG of just 2 frontal electrodes, F3 and F4, left side and right side. The blue is on the left, the right is on the, the blue is the left on the top, and the right is on the bottom. We're seeing peak alpha right here. So this is the frequency. So we're seeing peak alpha, but what you can tell about this, even without knowing anything about EEG, is that there is a big difference between the 2 sides. There is a difference in amplitude of the right and the left. And this is the fast Fourier transform in the 5 minutes post-laser treatment and you can see that they are virtually identical. Again, this is very preliminary, so disclaimer, but this is the sort of thing that we will be looking at in the study that I will be conducting in the very near future. So I have my training grant is funded by the National Center for Complementary and Integrative Health from the NIH, and I do have a small pilot study grant from an organization called NC TRACS, which is Translational and Clinical Sciences Institute at UNC. And I thank you very much for your attention, and now bring it on. Any questions?
Yeah, thank you very much for this wonderful lecture. I was quite happy to see the publication from Paulus, from Göttingen. That's exactly the study what I made with them, using laser needles on the brain. And it's exactly what's so amazing, that the excitability is going down. And so when we treat chronic pain, for example, what are we using? We're using acupuncture points on the body, according to the protocols from Peter Doscher, what you presented yesterday. And we always put the needles on the brain in the so-called government meridian. And also we use some special ear points, for the thalamus on the ear, for example. And I think that's amazing. And exactly these points on the brain are really important also for bringing the pain down. And regarding the studies with the heart rate variability, we have done a lot of work also in this. 10 years ago, we made a study on different acupuncture points and could show very, very good results. We made some preliminary studies with this new laser watch also, what Licha made already in Graz University, and showing red laser pushed first, but then it's going down a deep relaxation. And I will predict you will get wonderful results with this. Thank you.
Yeah, I really enjoyed your talk, and one thing which comes into my mind is especially the immunological status of patients who are suffering from chronic pain. We've seen in cancer patients that they have chronic pain. And is there any studies from yours? Because I don't belong to the laser community, so I don't really know whether people have used lasers to treat chronic pain in patients who are suffering from cancer, pre-op and post-op. And especially we have in HCG a unit where people are counseled before and after surgery because when you're diagnosed with an illness like cancer, it's very difficult for the patient to cope up with the reality. So they have a program where they program the person before and make him understand what he's going to go in for the next few weeks or months. So is there any integrative approach in which, because I think this requires a lot of integration, because standalone pain is, I understand, it's good, but chronic suffering because of psychosomatic conditions also bear immunological status, and that again has a response to chemo and radiation. So I just want to know whether you've even thought of tying these things up, because that would really mean a lot to the patient.
So yes, I have treated over my clinical lifespan, I've treated lots of patients with cancer who are undergoing conventional treatment, who are also undergoing integrative and alternative treatments. I do find that it is, cancer treatment often promotes central, basically sensitization, where the patient will have widespread pain. So I have found that the techniques that I use to be effective on that, not all the time, and not on every single thing, but for the vast majority of time, I would say it is effective. One of the things that I see in doing the cranial points is that the perception of pain seems to be decreased. All right? So I'm noticing actual physical changes in the target muscle, but the patient's perception of pain is usually decreased by 40 to 50% on average. So it's, again, it can be a very useful tool in treating patients with cancer. Yeah.
Nick, Lisa
yes.
here.
Hi, Lisa.
I'm sorry, I wanted to leap in before Mike did. No, that was humour, Mike. I was wondering with the rediscovery of the map, whether you'd looked at whether those points mapped to the motor or sensory cortices of the brain at all.
Mapped to what? Sorry.
The motor or sensory cortices of the brain.
In a word, I have looked at it, and there doesn't seem to be a direct correlation. There are other cranial systems as well, like in acupuncture. There is something called Yamamoto's new scalp acupuncture that doesn't seem to line up exactly with that either. Which was sort of disappointing and exciting at the same time. It seems like there's different things going on. Given that the motor cortex is pretty specific, there are some reflexes that cross that, but given the fact that the reflexes are all over the head, I would say it doesn't seem to be like a direct correlation, exactly with that.
Okay, thanks.
Mm-hmm.
So, great talk, Nick.
Thanks, Mike.
We were talking last night, and you said you basically used the same near-infrared laser for both the cranial reflexes and the cortical stimulation. So when you put the near-infrared laser on the reflex to trigger some acupuncture system and relax the neuromuscular junction, and the arm falls down. But these photons are going into the brain, and when they get there, they stimulate neuroplasticity and synaptogenesis. So, they will encourage some rewiring and your long-term... these are stroke patients who've got brain damage, right? In their brain, there is some dead brain that happened during their stroke. So possibly the long-term effects are attributable to neuroplasticity, and the short-term effects are attributable to some neuromuscular relaxation.
I think that is, I thought about it a lot after we talked last night, and I think that's probably at least the best idea that I have, or that I can come up with right now to explain that. I always considered the fact that in stimulating a point here, I always considered the fact that the light was going through to the brain as a wonderful side effect. That, in most therapies, the side effects are not something you champion and want a whole lot of, but in doing this and researching this, I thought that, that's got to be, that's a wonderful, that's not the direct application that I'm doing, but it can't hurt. It certainly can't hurt, and I think the longer term effects probably are because of that. Thank you for that.
Nicholas, it was a very nice talk from your side. I'm Dr. Madhusudan here. I work on chronic stroke rehabilitation programs. I do use a lot of neurodevelopmental techniques, including icing, acupuncture point, acupressure points, and also neurorehabilitation programs through physical therapy. And the way you have interpreted, laser applications on stroke patients, definitely we can work on that. Definitely we can make a pilot study here on stroke patients using your cranial points. Okay. Yesterday also, Peter, when he was emphasizing on baclofen reduction in paraplegic patients, it helped him to regulate tone well through lasers. And the way you have interpreted things with laser points through cranial system, stimulating cranial nervous system, possibly we can well work on tone regularities. Okay, thank you very much for your talk.
And just for stroke patients, I think it's important, so I'm just presenting data on using these reflex points, but I think that there is also, in combination with MRI, of actually looking at where the lesion is and, direct transcranial application of lasers to the motor cortex that is affected. I think that's, there are different ways of approaching this, and I tend to look at things, do the most I can, and get the biggest bang for the buck, so to speak. So I think there are synergistic ways of using reflex points and actual brain lasering as well. Anything else? Thank you very much.
Thank you, Nick. That was a very interesting talk, And I'm sure a lot of people would like to catch hold of you and keep you here in India itself. Let me now introduce Dr. Jyotsna Rao. She's a doctorate and she happens to be the research director in the International Stem Cell Services Limited in Bangalore. With over 30 years of experience in stem cell research, I request her to come in and give us a talk on stem cells.
Good afternoon, everybody. I thank the organizers for inviting me over for this global summit on lasers. Since I belong to the stem cell community and regenerative medicine, I'm going to be talking more about the regenerative aspect of stem cells and maybe how we could combine it with laser therapy and other adjunct therapies like acupuncture. That could be the later part of the talk. The outline of my talk would hover around regenerative medicine and how stem cells are an integral part of this regenerative medicine concept, how tissue engineering and other modalities form an multidisciplinary medium to address complex degenerative diseases. So what is regenerative medicine? It must be repetitive because this is the third day of the conference, but I have to go over it because that would be the flow of the talk. Regenerative medicine is a branch of translation research in tissue engineering and molecular biology, which deals with the process of replacing, engineering or regenerating human cells, tissues or organs to restore or establish normal function. And you could see here regenerative medicine can restore functions in all areas, including heart, stroke, and it could be Parkinson's and Alzheimer's. Several degenerative diseases can be addressed by stem cells. And the tenets of regenerative medicine are repair, replace, restore, and regenerate. And we could do so primarily with all the organs. In this picture, you can see right from the cartilage and the lung, if there is any disorder of the lungs which needs to be regenerated, or the kidney or the liver. Scientists are exploring regenerative medicine for a wide range of diseases. And this is a small list which I've just put up here. I just picked it up from a site which has described this. Cerebral palsy, diabetes, heart disease, spinal cord injuries, traumatic brain disorders, hearing loss, liver diseases, orthopedic injuries, ophthalmic diseases, muscular dystrophy, Parkinson's, stroke, and cerebral palsy. And this is how the FDA views the world of regenerative medicine, because it's almost like a melting pot where you have human tissues, cellular therapy, gene therapy, because you could use cellular therapy as a platform and introduce genes of requirement or whichever is required at that time, biological devices, combination products, xenotransplantation, and stimulators of endogenous repair. So all these things together constitute regenerative medicine. And I would call it a marriage of sorts because we have stem cells in the lab, and especially where I work. We have a dedicated CGMP facility where we can make clinical grade stem cells. We have tissue engineering where we have collagen scaffolds, several scaffolds, bioscaffolds where cells can sit in and be administered in areas of requirement. And the accessory modalities which would be an important accessory in our area of research, where we could use lasers or other areas where we could tweak the system and make it more favorable and get favorable results. So I'll just go over a little bit about stem cells. And we all know this. I'm just going to zip this by. And there are stem cells right from the single cell embryo stage all the way till the adult, where we have multipotent stem cells. And I would look at it similar to this graph here, this picture here, where we have stem cells, we have the growth factors, signals from within the cell, and we have all these branches which branch out to different parts of the body, and we require these growth factors and signals to ensure that all these things are working in order and synchrony. We have two sets of stem cells which we work in, primarily embryonic stem cells and the adult stem cells. The source for embryonic stem cells are embryo, and we do have ethical dilemma, and they do also form teratomas, which is unpredictable. The safer use of stem cells come from adult sources. All adult tissues do have a little bit of stem cells present in them. The challenge is to harness which organ will give the right amount of stem cells for us to use it for regenerative medicine, where it can be amplified in clinical conditions as a clinical grade stem cell, and it should not also leave its properties of stemness and become differentiated and cause problems of rejection later on. The purpose is to regenerate, and there has been no evidence of teratoma formation as of now. We have also had considerable experience in this adult stem cells, and we have found that there has not been any evidence of teratoma formation. So the sources of adult stem cells can be bone marrow, they could be cord blood, adipose tissue, placenta, skin, muscle, liver, pancreas, neuron, and mesenchymal stem cells. The challenge here is to use adult stem cells from a source which is easily available, which can be harnessed easily, amplified, cryopreserved for later use, and when it is thawed out in culture, it should retain most of the properties of stem cell and not undergo spontaneous differentiation and lose the expansion possibility of the cells. Where adult stem cells can be further categorized into mesenchymal stem cells, which is where it is considered to be the most versatile of all stem cells in regenerative medicine. They can be used across HLA barriers. Already Dr. Habib has told us about it, and we have used it in allogenic and autologous conditions. And there are some conditions, especially when we are talking about cancer modalities, cancer treatment, where the endogenous cells are not optimal. We do try to use NK cells or other cells coming from an allogenic source. So there are times where in clinical conditions, allogenic stem cells are better in terms of usage as compared to autologous. And you also have hematopoietic stem cells where you could get myeloid cells, erythroid and lymphoid. The properties of adult stem cells fall into two major categories: the self-renewal potency of these cells and the fact that they could differentiate. They could differentiate and also transdifferentiate depending on the cell type we use. Here we can see that these cells can undergo differentiation in the hematopoietic space. They can also become cells other than the hematopoietic, could become cardiac, hepatocyte, neuron, depending on the kind of cells you're using. And here is just a prototype of how we could harness this. And I've used bone marrow as an example, where you can get bone marrow cells derive, differentiate and give rise to red blood cells, hematopoietic stem cells, white blood cells. They can also give rise to neuronal cells, which could be a great tool for regenerative medicine. They could also give rise to mesenchymal stem cells, skeletal muscle, connective tissue, adipose tissue, bone and cartilage. It could also give rise to endothelial progenitor cells, which are extremely useful for myocardial infarcts and also for diseases which have clogged capillaries. So here there's a lot of debate about the mechanism of action of mesenchymal stem cells, because mesenchymal stem cells have been used across many disease types, and it has shown to be of great promise. But the question still remains whether the mode of action is fusion, the cells get fused into the system, or is it an anti-inflammatory immune modulation, or does it give trophic support, whether it actually has engraftment, whether it can be used as a gene delivery system, or it can be used as a cell replacement. So this debate is still, it's almost like a waging war in this field. People are more prone to understand the systems, and we find that mesenchymal stem cells are probably a paracrine and trophic support, and we have not found a lot of evidence where it can actually work as a cell replacement. But we are still working on this area, and maybe we could find ways in which cell fusion is possible when we could introduce other factors which could bring in fusion of cells. As of now, these two conditions are the conditions in which mesenchymal stem cells have shown great promise in our labs. This is a typical differentiation assay which we do in the lab, where we take mesenchymal stem cells and we show that they can become adipocytes, they can become osteocytes, and they can also become chondrocytes in culture, which gives us evidence to show that when we do regenerative medicine using these cells, then the potency of these cells, the possibility that these cells could differentiate into the type we want, is possible because we could tweak them in culture and give them the desired phenotypes. We were also able to convert these cells, the hematopoietic umbilical cord blood stem cells, into neurons. So, by saying this, I'm just trying to build in a premise that in culture we could tweak the system and bring them into a state where you could put these cells into the system and wish that these cells would do the job in vivo. When we have to bring that concept into regenerative medicine, we will first have to characterize regenerative medicine, which is a broad definition for innovative medical therapies that will enable the body to repair, replace, restore, and regenerate damaged or tissue cells, disease cells, tissues, or organs. And I just picked this up and I was making this presentation, and I found it extremely interesting to know Chris Mason and Peter Dunhill, who have written a beautiful review, an editorial on this definition of regenerative medicine. And they say that there are already a lot of definitions, but all are lengthy and not sort of things scientists, startups, or advocates can say succinctly when a pharma executive, government minister, or member of the public asks for clarification. And basically, this is a dilemma which we are right now in India, because we really don't know how to place regenerative medicine in the realm of modern medicine. Because there are people who would use regenerative medicine for anything and everything without validation. And the camp I come from, because I'm a scientist, I would like to have it validated. I would like to make sure that these conditions are replicable and I know the mechanism of action. So by doing so, this dilemma, the government is not clear as to where to place these kind of regenerative medicines, whether I could make the stem cell a drug or whether I should use it in the form of a medical therapy, a protocol in the lab or in the hospital. They also go on to say that in the medium term, there are a number of major medical conditions such as heart failure, insulin-dependent diabetes, spinal cord injury, Parkinson's, and possibly Alzheimer's, which appear to be addressable by cell-based therapies. A successful regenerative medicine centered on human cells could be a disruptive technology because it would potentially replace a number of major molecular pharmaceuticals and medical processes. So this is the dilemma in which we are now. This is the space in which India is poised, and I'm hoping that we will be able to make a breakthrough and categorize regenerative medicine under a category which is going to be an amalgamation of all the fields. I'm going to talk a little bit about regenerative medicine and stem cells, because it's very logical that when you're using a degenerative disease protocol, a prototype, you would like to use stem cells because it has the possibility, the ability to regenerate. And the potential uses of stem cells, I just picked it up on Google because it's everywhere, and you can see that you have all the way from stroke, all the way to cancers, diabetes. One could potentially use stem cells. And these are a few articles which give us an idea about what kind of research which has been happening in this. And this paper stands out because it says neovascularization of ischemic myocardium by human bone marrow-derived angioblasts prevents cardiomyocyte apoptosis, reduces remodeling, and improves cardiac function. And in our study also, which I haven't mentioned in this talk, we have also done a similar kind of study, and we have found and published in similar ways in which we find that there is neovascularization when you use autologous bone marrow. There are a few other papers which talk about phase 1 clinical trials in Crohn's fistula by adipose mesenchymal stem cells. Also mesenchymal stem cells for treatment of steroid-resistant severe acute graft versus host disease also. And this slide may not be very visible, but then it just tells us about the clinical application of blood-derived and marrow-derived cells for non-malignant diseases. And you have around 926 studies which have already been registered, and 3 meta-analyses shown, which tells us that there is a lot of promise in regenerative medicine using stem cells. This is the autoimmune diseases. Again, we've had some experience with it. I'm going to share a bit about some clinical protocols which we have done in our setup. And systemic sclerosis, lupus, Crohn's, multiple sclerosis are the few diseases which people have worked on with adult stem cells. This is myocardial ischemia, and this is just to show the indications being addressed using mesenchymal stem cells in clinical trials. In ISSL, we've had a little bit of experience with a few diseases which I have listed here. We started out first with myocardial infarction. We have done the country's largest trial with Buerger's disease, second only to the Japanese trial which has been published. We have had considerable experience using stem cells in scar management, and we have done it with patients with scars, acne scars, with cosmetic surgeons who wanted us to help them out with scar management. We have worked with multiple sclerosis. We've got wonderful results with rheumatoid arthritis. There's an ongoing trial which we have just initiated for male and female infertility, kidney failure, osteoarthritis, diabetes. We're doing a lot of cancer therapy based on the cell-based platform, cellular platform which we have created in HCG to treat cancer patients, especially oral cancers, head and neck cancers, and breast cancers. We have done a lot of patients, and the trial for liver diseases with Dr. Habib, we were a part of that too. We've had a trial on muscular dystrophy, spinal cord injury, and diabetic foot ulcer. And this is just a small list, but we are going to continue adding on more into it. This is neovascularization and therapy for limb ischemia, Buerger's disease. We have done over 150 patients. We have shown neovascularization. These patients are all lower socioeconomic workers, basically, who are heavy smokers, and their limbs would have been amputated. So we've been able to use stem cell therapy, autologous stem cell therapy for such patients. This is one more example. We have also worked with diabetic foot ulcers. We have shown vascularization by week 5, and the entire procedure is he completely recovers by week 6. Osteoarthritis, where we have shown hyaline cartilage growth, and the cancer therapy, where we've used autologous bone marrow derived stem cells to make dendritic cells, which can be used as vaccines for patients suffering from breast cancer and head and neck cancers. A little bit about the tissue engineering, because we found that when we do these experiments, clinical trials, the major problem we find is how to place the cells, because especially in osteoarthritis, we've had problems about cells not staying in place for a long time, and we've always wondered whether we should grow it on a scaffold. We are also having problems in the number of cells we have to put on the scaffold, whether all the cells are going to get differentiated into the cell type we want to, and how are we going to tweak the system in vitro so that we could optimally get the desired effect in vivo. So this is where we would like to use the tissue engineering concept and the interdisciplinary field applying the principles and methods of engineering in life sciences to fundamentally understand and develop biological substitutes to restore, maintain, or improve tissue functions is the definition of tissue engineering. and we would like to, the next phase of our research is hovering on the fact that we could use tissue engineering techniques to optimize our results which we are getting using adult stem cells. And here we have, and you could see, you can appreciate the fact that the growth of tissue engineering industry is going to be one of the major areas of research, because delivery of these stem cells are going to be of paramount importance. We would like to have stem cells in natural synthetic scaffolds, and the 3D printing is also very exciting, because you could bring in the desired nuances of a bone marrow into a 3D printing and hope that the cells will home in and function as normal as they would be inside the marrow in vivo. So these are the concepts where we are now trying to bring in these concepts into a lab, where we can design biomaterials and function in the body, have enough vascularity, plus the cost of tissue and organ development procedures should be such that it is affordable. We have to all do all these things in a CGMA facility for clinical grade stem cells. So this is where the company is poised now, and we would like to take this technology further in this domain. Cell therapy using tissue engineering requires the following parameters to take care of. You need to have a cell source which is immunocompatible. We already know, and we have considerable experience in mesenchymal stem cells. We are able to grow mesenchymal stem cells from the adipose tissue, from the dental pulp, from the bone marrow, and several other sources, including the Wharton's jelly, which is present in the cord. And the growth in cells active, and this part is kind of taken care of by us. But now we have to integrate this into a scaffold and bring this into a bioreactor so that we could step up the production of these cells and make it more deliverable. The natural materials which we are using right now is collagen, and we are also using hydroxyapatite. We are trying to use these scaffolds to bring in stem cells with it, so that the stem cells can differentiate into the desired output, because hydroxyapatite, we have some experience with it, and we have found that stem cells like to grow on them, and they like to become the osteocyte, the bone phenotype. And many of the dentists in India, they would like to use this product with stem cells coated on it. So we are actively working with dentists to bring in this concept of GTRs, guided tissue regeneration, using these scaffolds and stem cells together. And these are these few papers that started, the tissue engineering concept started in 1987, where there was almost like a wedding of sorts, where stem cells and other biomaterial scaffolds were used together for constructing tissues and cell deliveries. This is the last slide which I have, wherein working in stem cells for so many years, we have found that in vivo, understanding the nature of the disease is of extreme importance, because we have found that when we started taking patients and started treating them in a clinical trial, we found that the content, the kind of patients we got had a bearing on how the results would be predicted at the end of the therapy. Patients who came to us with early osteoarthritis, for example, we found that the results were extremely favorable. But there were times when these patients, although they had early OA, they had comorbidities. They were diabetic, or they were highly overweight, or there were lifestyle issues which we had to change. So we are now looking at the disease in a holistic manner, and wherein we put them onto a program where if these comorbidities exist, we have to first get rid of the comorbidities in order to give them the stem cell injection. And when we do that, we use the cells to be planted in a way in which they can sit there for a long time. The trophic effects of the mesenchymal could be maximized in that manner. Also, we are trying to see if we could use scaffolds right now, so that we could increase the presence of stem cells in the area, and also bring in some kind of a closure to the kind of expectations we have for the product, for the disease. The mode of injection I just spoke about, scaffolds for holding them also. We have also found that the number of injectable cells, because as the field of stem cells is maturing, we also find that these things, for example, the number of injectable cells, how many times you have to inject it, whether we could use other ways in which we could increase the potency of the stem cells. For example, whether we could combine this with laser is something which we would like to think about. Then in vitro manipulation of scaffolds using collagen membranes and other scaffolds, we have started working on them. This is the last slide, which is just going to tie up the entire talk which I have just had, where we could use cell therapy for tissue engineering. This is the only slide which I have for lasers because I only have this much experience in them. I would really love to have more in vitro and in vivo experimental designs made in order to understand how lasers work on stem cells, especially the stem cell differentiation part. Because we find that stem cell differentiation is not a complete effect. If you try to differentiate stem cells in culture, only a part of the stem cells would like to become the phenotype you would like to push it for. The rest of the cells do not differentiate. And that causes a little bit of a problem for us because we are not able to predict what happens to the remaining cells in culture. And what would happen if we put this in the knee? What would happen to the remaining percentage of the cells which have not responded to become a cartilage? So maybe if we could tweak the system further, bring in a tissue engineering model where we could make all the cells grow into a particular phenotype, plus use lasers in order to bring in and optimize the system, then we could predict better results for our patients. So I would like to stop here. This is just a graph where we've tried to use dental stem cells to work on the similar platform. I would stop here and thank you everybody for listening to me patiently. If there are any questions, I'll be glad to answer them. Thank you.
Great talk, Jyotsna.
Yeah, thank you.
In terms of fusing your stem cell at the site of injury, is there a particular application you're thinking about? Why would you want to fuse a stem cell with any other resident cell, especially in the site of injury?
When we have worked with the patients with multiple sclerosis, muscular dystrophy, we found that we were able to inject the cells. Initially we were trying to do muscular injections, and we did find short-term benefit with that kind of a procedure, but the patient who comes to us, if he is coming at an early stage, then we could probably address that issue. But when a patient comes at a later stage, when he's 6 years old or more, it's very difficult because the muscle mass is huge. So when we do muscular injections, we were able to find that there were some effects, but they would not be long-lasting. So we would think that the only way we could do it was to use an arterial approach, which could still go in and home into that muscle mass. But we still don't know whether the cells are able to fuse into the muscle mass, because we are not able to understand whether the trophic effects of mesenchymal are there and then they just die away after 3 weeks, and that's why the effect is not long-lasting, or is there any other way in which we could optimize that condition. So that is the reason why we feel that fusion of cells in some conditions are required.
Okay, that was one context I think which makes a lot of sense. Because in other cases where you have an injured cell or a diseased cell, you would rather not have a good cell merge with that cell for itself.
Yeah, sure.
Okay, and the other question that I think, rather a comment more than a question, is you were talking about how you want ideally 100% differentiation of cells at a site of injury. Don't you think that by even partial, let's say 80%, 60% differentiation, the other cells in that milieu would actually act as trophic factors?
Yeah, I mean, in vitro I have not been able to validate that, because when we differentiate the cells in culture, we find that 30 to 40% of cells, let's say if it's a chondrocyte differentiation, they differentiate into chondrocyte, but the rest are not differentiating at all. So now in vivo, I'm not able to validate whether the remaining are actually giving in a trophic effect. Because when we do patients with osteoarthritis, we do see over time, 3 injection protocol, we do see robust growth of hyaline cartilage in these patients. The WOMAC index comes down and they are clinically, we feel that it has worked. But I still don't know what happens to the remaining, whether they have aided in regeneration or are they going to be trouble later on.
I see.
Because I am not sure whether they will create fibrosis, because they are not going to differentiate anymore, I know that. But are they going to be eliminated by the system, then I would be happy. But then I am not able to know what happens to that. That's the reason why I feel that if I could optimize the system, and also the number of cells we inject will also be optimized, because now I have to take 30%, 70% more cells in order to give the number of cells into the body. So this is just tweaking and making sure that all the sites are covered when we enter into a clinical trial.
I just want to make a general comment, because this is a unique conference, because we are, for the first time, we are bringing lasers and stem cells on the same platform. And in India, of course, we have never had this, occasion before. I would like a few comments from the audience and people who have been here all 3 days. Is that what is the way forward in integrating the stem cell field and the laser field? Because obviously there are a few things. We can talk about differentiation, aided differentiation using stem cells and lasers. Maybe also in the in vivo setting, say, what are you going to talk about? Where does stem cell and where is the interface of stem cells and lasers going to be? Any takers?
Well, my comment comes straight from the fact that we are trying to do a lot of this in lab models, nonetheless. If you prepare the site of stem cell delivery by reducing either the inflammation or preparing a nice niche for it, I think you'll get better results with MSCs. One suggestion I think Mike made to, I forget the speaker, but you could pre-treat your stem cells before transplantation, and they would potentially be much more mitochondrial metabolically active. That could also aid with some of your treatments. And obviously in combination, when you have a rationale, in our case we are looking at a very specific growth factor pathway. When you have a very specific rationale to why or what the laser is activating, then it would make sense to actually combine that therapy in a given context. Almost all our treatments are done in the teeth, in the present, where you have pre-odontoblasts or dental stem cells primed to become odontoblasts. So we need a very gentle nudge with the laser via the TGF-beta pathway. But in more complex cases, you might have to engineer different material systems or combination of material systems, soluble cues, insoluble cues to get to that same endpoint. So those are the 3 or 4 strategies I think that would be attractive.
Yeah, and I think we have to come back to the basic things, to the mitochondria, And stem cells, they need, of course, energy. First of all, they need energy to survive after injection, maybe in a joint or anywhere else. And then they have to differentiate. All these processes need energy. And so what we're supplying with the different lasers, maybe all the spectral colors, we provide them energy. That's how we are thinking how lasers work, even maybe by intravenous laser or something. We always get some stem cells out released from our bone marrow in the bloodstream, and after maybe 10, 20 treatments of intravenous laser, we see improvement of kidney function and liver function. We have very nice data showing improvement of the injection in cardiomyopathy, and that's something I think we have to go back to the basics, to the mitochondria, and find a way to bring the laser everywhere in contact with them.
I agree. There should be a little bit of more validation in terms of in vitro protocols when it comes to stem cells, because mesenchymal stem cells are also known to secrete a lot of exosomes, and exosomes are extremely therapeutic but has not been characterized well. And now we add on lasers on top of it. We really don't know how we are tweaking the system. So a considerable amount of in vitro assays to validate the process before the in vivo settings come in would be a good amalgamation of stem cells and lasers, I would think.
But there are already studies available, literature showing also in vitro experiments effects on different lasers on proliferation and differentiation of stem cells. There are already studies done.
Okay, I'm sure, because I am not very much aware of that field. Thank you very much. There's one more? Okay.
I just want to add a comment. I think the two areas that would be very effective are increasing proliferation rates, and the other is increasing survival post-transplantation, because loss of cells after transplantation could be very, very high. The question about differentiation, for me, that's not as clear that light is pushing them down a line unless they're sort of already going that way. It seems like in a lot of that work, people are adding external factors and light. So light alone causing differentiation, and you know, I may have missed something, but I don't think that is as clearly defined. One of the things we did find in our lab a couple of years ago was that we could proliferate stem cells without adding any factors. So you know, when you grow stem cells, you have to add this soup of factors, right, to get them to proliferate and then differentiate. And we were able to get these cells with just light to proliferate. And when we looked at RNA and protein production, we found that the light caused the cells themselves to produce factors they needed for their proliferation. So I think really proliferation and increase of survival are two major areas.
Yeah, I agree.
And I think differentiating between the two is pretty important, because when you're trying to proliferate stem cells, which is counterintuitive because stem cells do not usually proliferate, you're talking about expansion of a pool of cells amenable to either generating trophic effects or regenerating some tissue. So we, at least, and I agree with what Connie is saying, lasers have a role in both expansion as well as differentiation.
Yeah, I mean, if you could tweak the system in order to get a good expansion and then tweak it again to differentiate, then you would like to do it without the effect, I mean, the addition of any growth factors. That would be really nice. That would be a good system to work with.
You know, there are different groups in Israel. Maybe you know Professor Slavin. They expand them and work with different microRNA to direct them already to go into neuronal cells or pancreatic cells or something like this. But then we have again the problem, you know, then we are starting manipulating the cells, and and then we have a legal problem with this. Huh?
Right. Thank you, Doctor. That was a very, very interesting perspective to the whole thing. Now, before lunch, to increase our hunger, we have with us our valedictory speaker, Professor B.M. Hegde, Padma Bhushan awardee and a B.C. Roy awardee, a cardiologist and the retired Vice Chancellor of Manipal University. Today is one of the most vociferous proponents of complementary and alternate medicine. So I request Dr. B.M. Hegde to come over and address us on his perspective on lasers and India.
Thank you very much. I won't stand before hungry people in the audience and your food, because hungry people are always angry people. I'll give you a different perspective altogether. I was not going to talk about lasers because I'm ignorant about them. Neither am I talking about stem cells, because my experience with stem cells in the clinical practice has been miserable. And so let's not go into that. I'll just give you a perspective. What would be the future of medical science? Because ultimately that's your aim, no? You companies, of course, want to sell whatever you have, and then you try to show that it's the best that can happen to mankind. If you look at the history of medicine, you have had a lot of these things happening over time. But let me remind all of you one small thing. History of medicine is very important. If you do not learn from history, said Cicero, You will have to relive history, which is absolutely true. Let me come to science. You know, I heard this word science. I'm a scientist, I'm science. This. What is science is a question. What is science? Let me remind all of you that science is simply learning from nature. You're talking of regenerative medicine. Let me remind you, you have seen salamanders in your house? Cut the salamander's tail. After 2 days, you see the tail growing. And after a month, you see the whole salamander tail back again. It regenerates itself. And the stem cells that it produces are called endogenous stem cells. The first doctor ever to think of the stem cells in treatment of things was Dr. Beck, Robert Beck, professor of orthopedics in New York in the 50s, colossus in the field. And Dr. Beck had observed something. When a bone fractures, the doctors set it back. They probably also put a shield on outside cap. But what heals the fracture is the nature's way of healing. How does it do that? So he is observing, you know, when a bone fractures, the periosteum gets lifted, and then there's a small little clot. So this doctor in the electron microscope, when it first came, was examining this clot. Very interestingly, he found that the RBCs after about 3-4 days started becoming bigger and started putting out pseudopodia and eventually became the stem cells. These are pluripotent stem cells. They can grow into bone, they can grow the nerves together, they can grow the muscle together, they can grow the skin together, and the whole thing heals. So healing is done by the nature, and healing is the nature's method of keep going. Why have we forgotten all that? Because the reductionism came into science. Starting with René Descartes, the Descartes' idea of cogito ergo sum, I think, therefore I am, and this world runs because of my thinking, upset the whole apple cart of science. Luckily, now we have come back. We're talking so much about genetics, stems. A human genome, metagenome, contains only 23,000 human cells, human genes. 23,000 human genes. Remember that? Even a round earthworm has got 23,000 human genes. Even a rat has 25,000 human genes. So with that, we can't manage the whole show. But we have also got 2.5 trillion germ genes, virinomes, germinomes, metabolomes. So all these have a contribution for evolution of man. And we are more germs than as human beings. And we don't inherit anything from our parents, as we say, genetical inheritance of diseases, etc. It's all just to frighten people. Now the future science is already there, and that's quantum physics. And quantum physics has completely changed the conventional science of physics, chemistry and biology. Biology has changed from the conventional biology that we were monkeys and then we all... I'll ask you one small question about Darwin, what Darwin did not know. If we have evolved like that, at one stage, let us say I was a fish. Now why did I become a bird? It's very nice to live as a fish because you have only one circulation, permanent circulation, no lungs. So many diseases don't come. Or for example, I was a snake, let us say. Why should I become a man? Because snake has no coronary arteries at all. Snake sucks the blood for the heart muscle from the cavity of the ventricle through holes in the endocardium. And in total myocardial revascularization, we are making a man a snake by making holes in the endocardium and seeing that the man survives. So the evolution that Darwin taught us, which neo-Darwinists are trying to sell, because Darwin himself at the end said, look, evolution is environmental, not genetic. It's more environmental than genetic. Now if environment is the important thing in epigenetics, you come to the human body, you put a stem cell from outside, which is the exogenous stem cell. Now what happens to the stem cell? The stem cell, if it has to do anything it has to do, now you are saying, I will teach this by laser, I will teach that, I will do this, I will give energy. Whatever it is, the environment has to dictate it. And the environment today we know is the consciousness, which has come into science now. And consciousness is something, consciousness is fundamental. All matter grows out of consciousness. There is no matter at all. If you want to know how matter was considered to be the last thing and we are trying to meddle with matter, there came a stage where even nuclear scientists were doing, I'll quote the man who found out that matter is not matter. And his name is Hans Peter Dürr, who was the director of the Max Planck Institute for 20 years. Hans died recently at the age of 90. And Hans says, I'm quoting Hans now, I'm a nuclear scientist. My job is look at matter at the subtlest level. I started with Einstein, then with Werner Heisenberg, and now I have the director for 20 years. At one stage I found there is no matter at all. What was they looking for? Matter. And at one stage I found there is no matter. So he has written a beautiful book for all of you. And I'll give you an article which is easier to read. Go and read in the evening in your room. Matter is not made out of matter. Matter is not made out of matter. Matter is energy. And this is a beautiful article which will tell you that all that we have been doing, barking up the wrong tree in reductionist medicine, we have now come to vivisectionist medicine. We have not even come to reductionist medicine. Let us remember one fundamental thing. This human body is not built like a motor car for you to meddle with each organ and the cell and things like that. Human body comes from one cell, the zygote, the cell that you were in your mother's womb when the day you were made, a fusion of the father's spermatozoon with the mother's ovum. That one cell gets the consciousness, and when it gets the consciousness, it starts working. And this was a stage, a cell biologist like, what's his name, Dunlop. He first saw this happen, and he was an atheist. He became then on, he believed in something which is outside the human effort. And this stem cell grows. And that one single cell is what you are today, 100 trillion cells. And all cells are connected to each other. As a matter of fact, the genetic pattern of a brain cell and its neighboring brain cell could be different. But the genetic pattern of a brain cell and a heart cell could be identical. So we have not been able to identify the metagenome at all. The NIH, quietly, without telling anybody, spending millions of dollars, tried to get the metagenome. And after about 10 years of working and spending lots of money, they got just this two special genes of the metabolome. So they said if all the laboratories in the world were to work every day only on genetics, we will probably be able to take another 100 years to really get the 2.5 trillion germ genes in the metagenome. So the idea is that the human body runs with consciousness. Max Planck said, consciousness is fundamental, everything comes from consciousness. And if the consciousness is the fundamental environment, if you put a stem cell inside, and what the stem cell does depends on your consciousness and not on your external in vitro studies. So the future is going to be the consciousness medicine, consciousness study, which is called quantum science. Now remember, this world had a worldview, which we still live in that worldview. Newton's and Einstein's worldview of space and time. And this worldview is completely wrong because it can only grasp what you can really grasp. What is science? Your five senses. But in quantum physics, you can comprehend much more than what you can grasp. And quantum physics now tells you that human treatment and management is in the human body itself, and you should only facilitate the human body to treat it. It's called quantum medicine. And quantum medicine is coming out in a big way. And there are institutes of quantum medicine cropping up all over the world. And there's an institute coming up in Bangalore. Very soon you will know there is a quantum medicine university coming up in Bangalore. Anyway, this has also become a business now. But ultimately, quantum medicine is something which every human being can have a control over. I'll give you, there are a lot of studies published on healing human beings, regenerative healing, without any outside help. This is because, after all, your consciousness is your mind. Where is the mind? We thought, in reductionist science, we think the mind is in the brain. That is why the whole specialty of psychiatry grows. We give chemical drugs for every psychological disease. But the man who said the mind is in the brain and got a Nobel Prize for that in Canada, Montreal, Wilder Penfield, has written in his own book saying that I'm sorry, I'm wrong. Mind is not in the brain. Mind is outside the brain, in the consciousness. And that's also in the brain. So mind is not the mind is not the one which controls the human body. It's the consciousness that controls the human body. So having said that, the future medicine is, that's the topic I was supposed to talk about in the valedictory address, the future of medicine. Predicting the future is very difficult, remember that. We have been predicting the unpredictable future. There's a nice article if anyone is interested. Doctors predicting the unpredictable future of patients. And this is what we are doing every day today. And this article is written by a physicist in a medical journal called the British Medical Journal. His name is William John Firth, F-I-R-T-H. And Firth's article is Doctors Predicting the Unpredictable Future of the Patients. And it's in British Medical Journal. Year is 1991. Volume is 303. And page 1565. Please read this article. It will tell you repeatedly. And ultimately, what is healing? Healing comes again from the consciousness. I'll tell you some study, very nice study done recently in Oxford, Cambridge, Hamburg, and one more university in Europe. They did a study monitored from Oxford. Professor Bingal is the professor of medicine in Oxford. What they did was they injected morphine intravenously to patients with severe pain, the pain which you have not heard of. And morphine is the best drug going intravenously. But they told the patient, this is not morphine. What you are getting in the injection is not morphine. It's a new vitamin we have discovered, B17. And it will improve your health but may not remove your pain. Lo and behold, 88% of the patients did not have pain relief with intravenous morphine running in their vein. They did a crossover study, took the patient to the other side, ran saline drip and told the patient, this is morphine, the latest salt of morphine, very powerful. Your pain will go. All their pain disappeared. Doctors are nonplussed. They said, what's happening? So they said, let's repeat the whole thing with fMRI. They repeated the whole thing with fMRI. And what the fMRI showed was, when the patient believed his doctor, which is called belief, but in Latin it's called placebo effect. And the placebo effect said, look, this is not morphine, so my disease is not going to get cured. And his pain never disappeared. But when the patient believed that salt water that he was getting is morphine, very interestingly, his forebrain produced such powerful opioids, his pain disappeared. So this confirms experimentally on the laboratory that the placebo effect is a reality. And as a matter of fact, now placebo effect is coming to coming as a headache to the drug companies in the United States of America. You can't get a powerful drug produced to pass the FDA showing that it is better than placebo. But the general placebo effect in the population has risen from 23% 10 years ago to 56%. And it's very difficult to get a drug which is more powerful than 56% effect. So much so, the placebo effect is the one that ultimately does. Now what do your drugs do? You think, we are using so many drugs, we are doing surgery. Okay, you are doing surgery and saying that I am doing surgery, it's doing. There's a nice study from Harvard. We showed laser revascularization of the myocardium. They did a random study. First patient went to theatre A, second patient went to theatre B, third to A, fourth to B. And at the end of that, they found the protocol in A was anesthetize, operate, send. Patient doesn't know because it's only an injection that is a small little catheter that is going in. Chest is not cut open. The theatre B, anesthetize, keep him sleeping. When he wakes up, tell him he had a wonderful operation, send him home. So over a period of 5 years, they had 300 patients in A, 300 patients from B. And after 5 years now, all those 300 went to B and not had an operation but were told that they had the operation and they believed it. They have got beautifully revascularized myocardium now. Scanning showed myocardial revascularization is perfect. In A, half of them needed open surgery because their pain disappeared. And the other half are with their maker in heaven. And rest of them are suffering from ADR, adverse drug reactions. So even surgical result is a placebo effect. All this boils down to one thing, that it is the consciousness of the man or a patient or a woman, and that's what treats the diseases in future. Already there are now quantum institutions doing a lot of good work. So it may look like, now it may look like something, hearsay or a story. But this is the truth. And science is change. And what does not change is not science. And change comes with more and more ideas about how the human body works. And the human body works, mind you, there is a very nice study done in Amazon forest now. In Amazon forest, there are aboriginal races who have no touch with reality at all. What we call reality. And they don't even a small little underwear. Everything is, but they live up to 100 years. What they found in this study was that they have methods of curing themselves without any external evidence or external intervention. And they live long. And now people are trying to make it an industry to find out how they live so that we can make a business out of it. Ultimately, today science is money. And if science is removed from money and made free, you will be a different human being altogether. There's a great scientist in Cambridge who was denied his Nobel Prize, though he deserved it so much, Sheldrake. And Sheldrake has clearly shown how you can know a lot of things about yourself if you know how to control your consciousness. He has written a nice book for all of us to read. Even dogs know when their owners are coming home without seeing the owner. And they know exactly what time the owner is coming or not coming. And this is because science is now, what is science today? A, getting grants. Whoever gets a greater grant is called a greater scientist. Writing what is called papers. you will be surprised. Even in a journal like Nature, in 1 year, 3 years ago, 17 papers had to be retracted. In a journal like Science, these are called the top science, 7 papers had to be retracted. And the peer review system is a system which is developed over the years to see that any outside thinking, out-of-the-box thinking, does not get published. Now, if you are a conventional thinker, after all, 5% of this world's information is known. 95% is not known. And 95% you don't know. And you just dwell in that 5% and write heaps and heaps of papers and get more and more grants. And would you be surprised that now they have found Nature and Science are a club where they have a closed thing and they publish whomsoever they want to publish. Actually, Shackman, who got the Nobel Prize 3 years ago for medicine, called a press conference and said, I have stopped my university for sending any paper to Nature and Science for the simple reason that they want to keep people outside. They have got a peer review system which keeps people outside. So friends, it's a pep talk that I have given you. Go home and think. And I know what you will say when you go. After all, I had a friend who was parish priest, was going from place to place giving lectures. One day he was giving lecture in the Sheraton Hotel in Bangalore. That was a Sunday and he was a Protestant priest, so he had a wife at home. In those days there was no email. He wanted to write a letter. He wrote a letter, went out in the morning on a Sunday, and he found he didn't know where the post office was. So I asked a couple of kids playing on the roadside. He said, where is the post office? They said, come on sir, today Sunday, we have holiday. They took him to the post office and he posted the letter. On his way back he said, look, I am a priest. I should be grateful to these kids. What do? I buy some chocolates. So I went to the shop and then found his valet was in the hotel. So he told the kids, don't worry kids, evening I am giving a lecture, wonderful lecture. You have to pay 100 rupees to listen to my lecture. But here is a small chit. Go and give it to Vani. She is the organizer. And she will leave you free. So this is for helping me to find the post office. On the way back, the children said, sir, what are you talking about? Oh, me? Talking about? I am a priest. And I am talking about God. I am talking about heaven. Way to heaven. Way to God. The children burst out laughing. I said, why, sir? Sir, a man who doesn't know the way to the post office, how does he know way to heaven? So that is what you will say now. But 10 years from now, I want you to audit yourself. I know you are all young, you will be there 10 years. 10 years from now, you audit yourself. What did my stem cell do? How much have I progressed with stem cells? I have interesting patients. So a lot of money, they go to Bangkok and get their stem cell done. And then, when they are very bad, they will be palmed off, saying that you are better off for a palliative care in India. And they come here to die. I want you to think. I think scientists must pause for a while and think. Where are we going? Which direction are we going? Now, evolutionary biology tells us that we evolved as human beings only. We were human beings only. We were not monkeys. We came here. But in systems biology, the human biology is a closed system. A closed system is something which abhors outside intervention. We have been treating the human system as an open system in our conventional biology of the 18th century England, where for every disease we have to intervene. There's the pill for every ill. Read my article in the British. While there is no pill for every ill, there is an ill following every pill. And this is what we have to understand, because as a doctor I know our biggest problem is not any one of these treatments. ADR. Today every elderly person has 20, 25 tablets. And God only knows, except God, because science they can't understand, how do they interact and what happens to them. Do you know why most people survive in spite of us? Though of course we are the leading cause of death, we are the weapons of mass destruction. But what really keeps them going? A study in America showed that if you gave a man one tablet a day to remember, 76% only remember that. The other 24% don't take the tablet. Now if you make it 2 tablets, this compliance comes to 42%. If you make it more than 3 tablets, it comes to 23%. That's why 77% of the people who are given treatment by doctors don't take it, and that's why they are alive. Thank you very much. May God bless all of you.
Thank you very much, sir. Absolutely out of the box. Let's have lunch.